morning, everyone. Thank you for coming today. As breast cancer survivors and care partners, you know the myriad of questions and uncertainties that can come with that diagnosis. MYOH is committed to providing the most up-to-date medical treatments, but also offer adjunctive services to empower patients to tell their unique care stories and achieve their goals. NYOH offers a robust program of clinical trials, including phase 1 studies, cancer genetic testing, and a variety of imaging services, including CAT scans, PET scans, and mammogram and various ultrasounds at our Akira Medical Imaging Center. Adjunctive services are offered that provide educational and financial support through the MYOH Foundation, who is supporting this program today. We have a menopausal weight gain and symptom management program through our gynecologic oncology service and partnership with 2Life to help with mastectomy bras and prosthesis fitting at our various offices. In January, we're going to be opening the Regional Cancer Center near Crossgates, and we're hoping this is going to be a state-of-the-art center that's going to bring together all kinds of care providers to work in conjunction with one another to provide the best possible care and offer a unique experience in the capital region. We are so fortunate to have Dr. Theodoulou join us from Sloan Kettering several years ago. As many of you know, she's a world-renowned breast cancer-focused medical oncologist with boundless enthusiasm and passion for caring for patients and improving the care of breast cancer. So without further ado, I introduce Dr. Theodoulou.
So thank you, Dr. Tedesco. Karen Tedesco is the president of NYOH, brand new president of NYOH. Let's give her a round of applause. Thank you. So, number one, thank you for taking one of the best days that we have this summer to come here today. I'm hoping that this is going to be a program where everyone walks away knowing one thing that they didn't know before they came into the room. I want to be hopeful. I want it to be fun. We have an incredible array of faculty in all different subspecialties. No slides, nothing that's going to be over anybody's head or patronizing. This is going to be a conversation. We're going to use our voices to help you all find your voices. And we're going to listen to your voices to help us expand our hearts to continue to understand all the unmet needs and the needs that our patients so duly deserve. I'm really excited about this program. I've done a lot of these, usually small groups in back rooms, in church basements. After the pandemic, we kind of eased off for obvious reasons. And one of my patients from Memorial Sloan Kettering Cancer Center, Stacy Rosenthal, has been incredible since I arrived here. Year after year, she has donated funds for me to continue educational programs. Well, the bank got quite large, and we were able to pull this off today. Stacy was diagnosed with a very high-risk, multiple lymph node positive, aggressive breast cancer over just about 2.5 decades ago. And she was treated with what was state-of-the-art then at Memorial Sloan Kettering and what continues to be the state-of-the-art for non-HER2 overexpressing breast cancers that are high risk. You can see in this picture on the, I guess that's left, I'm dyslexic, that's why I become a surgeon. So you could see on this, and I'm pilot, isn't that scary? So you can see on the picture on this side, she was photographed for the Sunday Times with her husband and her son, who in solidarity shaved their heads when she lost her hair. And about 25 years later, you can see on the other side, there's Stacy with her husband and that same son and his child. So she can't be with us today. She's moving. It's moving day into a new home, but she's with us and she's made this possible. And through her grant, we have been blessed with multiple support from so many wonderful exhibitors. Met some of them downstairs. AstraZeneca, Natera, Acuity, Gilead, Pfizer, who really went overboard with their grants. Come on in, take seats, don't be shy. At the collaborator level, we have Caris and Merck and Genentech and Myriad, Stemline, Puma, and the AXI programs. I think we're going to have a lot of fun today. We have panels that are very diverse and I think very exciting. So with that, I'd like to get started. And our first panel is going to incorporate what is breast cancer. So I'm going to ask Dr. Gunovich, come on up. They actually lit the back staircase. Hopefully we won't have any accidents this year. Dr. Plitas, where are you? There you are. So handsome, that red tie. Oh, wait a minute. Dr. Rourke, let's see you walk. Look, if you can see the shoes, you'll see them up on the stage. I feel like we should have drum roll right now. And I think Dr. Oles, come on up. Okay. Come into our living room, please. You can see we've really bent the rules. We're not doing this with a big table microphones. We're going to do this in a very comfortable way. Please come on in. And there she is. They did like. You can see that. So what we're going to start off with today, our first panel, is really how does one find out that they have breast cancer? And what is breast cancer? And then how do we move forward for local control and really increasing survivorship? The mortality of breast cancer has decreased, but the numbers have not. And I will tell you what's striking to me. I've always cared for pregnancy-associated breast cancer and young-age breast cancer. I've been doing this for over 40 years. But it's striking to me in the past 6 months, great bulk of my patients are between the ages of 20 and 35. So we really have to look at that and try to understand what our life goals are, what our lifestyles are, what our environment is, all of the above. And I can't explain it. I don't have an answer. We're seeing it in pancreatic cancer and colon cancer and other cancers. But I'm going to start this off with just a brief story, and then we're going to kick it off to the panel, and I'll introduce them. Some of you have heard this, who have heard me speak before, but in my first week of my first year of medical school, first Thursday, our whole group was signed every Thursday afternoon to follow in the community somebody with an MD or DO on the back of their name. Why? Were we going to learn orthopedic surgery in one afternoon, psychiatry, family medicine? No, it was to learn the pearls, how to knock on the door, be respectful, speak the language in a fashion that the patient would understand and you would understand them. Listen to the story. I'm assigned to a medical oncologist up at Roswell Park. And I showed up that first day, and we're talking a long time ago, back then when the charts were on the door with all the information of patient facing outside. It had the name of the patient, their date of birth, what they were diagnosed with, and sometimes in red they write, the parter is awful, don't let them back here. Anything could be on that, everybody to see. It was pre-HIPAA. The nurse came over to me and she said, you're going to meet a patient, 77 years old, diagnosed with breast cancer 7 years ago. And she had a mastectomy. She had a surgery. She didn't say mastectomy. She had a surgery, and she's coming in from farmlands about 4.5 hours away for her 6-month well care. Trigger. So I went in. What was I going to talk to this woman about? I knew nothing. We talked about her farm and her harvest and her family. I looked under her robe, and there was only one breast. And I stepped back and waited for my attending physician to show up. Back then, we present the case, and we would go into the room together and we would see how the case should be addressed. And my attending said to me, tell me about the patient. I thought I was so slick, so smart. I said, 77-year-old diagnosed with breast cancer 7 years ago, mastectomy, here for 6-month well care follow-up. I thought I should get an A++. I said it all in 15 seconds. Until she said to me, what does a mastectomy look like? Well, I said it's the absence of a breast, and there's a scar that starts in the middle of the chest, and it runs up and down in a raggedy fashion from all the way up to the collarbone, all the way down to below, above her abdomen to her armpit. She said, really? She said, let's go in. And she asked the woman, can you tell this young, I was young then, tell this young doctor how you lost your breast? She said, oh dear, she said, I was helping my son on his farm. His wife was about to have a baby. It was harvest time. And as I bent over to pick up my basket of whatever it is, I still, all these decades later, don't remember. As I bent over, my breast fell off. This woman had never been to a physician in all of her life. All of her children were born on the farm. She had a lump in her breast dating back about a dozen years before this event. She thought it was a boil. Sliced potatoes, sliced cucumbers, everything holistic. It didn't pain her. This thing grew and grew until it replaced her breast. And this piece of stone, just by sheer gravity, when she bent over to pick up that basket that day, pulled away from her chest wall. The family drove her. You're supposed to go, ah. The family drove her immediately to the big city, got rolled into the operating room. They cleaned the wound, thereby the raggedy incision. They took out 22 lymph nodes. 22 lymph nodes. Should I ask you guys how many lymph nodes were involved by cancer? I'm not gonna ask you. Zero. None. None. And this was before radiation to the chest wall. This was before tamoxifen was approved in the adjuvant setting. And there she was, coming every 6 months for a hello. And I thought, well, what's the big deal about breast cancer? Until that afternoon, I sat quietly listening to my physician, who became my mentor, interview a 32-year-old patient who was diagnosed with a stage 1 breast cancer just under 2 years before. She was there with her husband and her parents. She exploded with metastatic disease within a year, and they were there to discuss end of life. And she did die 2 months later. We didn't know what HER2 was back then. We didn't know how to triple negative. We didn't even understand anti-estrogen therapy. I went home that day and I knew 2 things. That number one, breast cancer was a lie, and Anna, this is going to be your introduction. Breast cancer was a lie. It was not one disease. It was multiple diseases. And second thing was I was hooked. That was it. I was going to be the Columbo of breast cancer. But with all seriousness and all respect, I have never been bored. I relish every day that I come in to meet a patient, to the intimacy of that room, the stories that are told. But I learned early on, not what's on a piece of paper. I learned early on what breast cancer feels like, smells like, acts like, and it behaves so differently, just like we're all different in this room. But we come a long way. Should I say we've come a long way, baby? Yeah? Okay. All doctors smoked back then when I was training. So what I'd like to do is introduce our panel. This is Dr. Anna Bogdanowicz near me, and she is a pathologist at Albany Medical Center. When I came up here 10 years ago, she didn't know. A lot of people didn't know. I vetted who I was going to work with and who I was not going to work with. And I knew that if Anna read and dictated a report on a patient, that it was equivalent to any of my Memorial Sloan Kettering pathologists. And she's been a great support, a great boon for the patients up there. And Anna, I'm going to throw at you right now, what is breast cancer? And I'm going to take a back seat. So, is it working? Yes. Okay. Can you hear her?
So that's a very loaded question, not easily answered, but pretty much to define it in very simple terms.
Okay, hold it right here.
So to try to define breast cancer in very, very simple terms, it's when a normal cell, acquires a type of mutation, a change in its DNA. So normal cells, we have trillions of cells in our body, and they are constantly breaking and repairing themselves. This is normal. This is how we exist. But there are regulations, and they repair themselves and they move on. In a cancer cell, that doesn't happen because they acquire this change in their DNA that allows them to just avoid the regulations and they don't stop dividing and they continue to divide. And that is what cancer cell is. It's an abnormal cell that has acquired the ability to continue dividing and avoid the signals that tell them to stop. Ultimately, due to, again, changes in the DNA, these cells may acquire the ability to break past the walls that surround them. So the cells have, again, I'm just trying to paint a picture that perhaps you can understand. The cell is a matrix around them, and this prevents the cells from moving. But again, they acquire this ability. It could be due to genetic factors. It could be due to, external factors, chemicals, alcohol, smoking, and lung cancer, a variety of factors. They acquire this, mutation, this change, and then it allows them to break through these barriers that keep them in place and penetrate into the tissue that surrounds it. But then you say, well, some people have this happen to them and nothing happens. They don't go beyond that, right? Other people develop metastases. So it's a very fascinating and a very complicated system because just because a tumor cell acquires this ability to invade doesn't mean that it's going to go anywhere, because the next thing is it has to acquire the ability to get into a blood vessel so that it can travel. Once it's in a blood vessel, it has to have the ability to evade our immune cells that are in there searching for these invaders and trying to neutralize them. So it has to develop that ability. Then it finds its new home. Let's say it ends up in the lung. Well, it doesn't just land there, it has to have nutrients. So it has to have the ability to develop blood vessels and to access those nutrients. So all of this actually is great because it means most cells that acquire this ability to become malignant, to invade, to metastasize, really don't survive. And only a very small minority of these cells actually, can metastasize and, establish a new location. So that's really what cancer cells are. They're just abnormal cells that are constantly dividing.
When I want patients, I tell them that if I buy a packet of seeds in a nursery, and I share the seeds amongst the 5 of us up on the stage, and we all go home to our individual gardens and plant the seeds, and then we're all going to get back together to talk about what grew. In one garden, nothing may happen. In another garden, the seed may germinate, but it doesn't have the potential to create a stalk and break through the soil. In another garden, there you go. Now you've got a stalk, you've got a flower, it looks real nice. But in the last garden, that stalk and that flower may create seeds, and those seeds may land someplace else. So it depends on the wind, the temperature, the soil, pH, the acid base, and similar things are going on in our bodies, because even with those seeds landing in someone else's garden across the way, they may not have the nutrients. They may not have the endogenous or exogenous hormonal factors. They may not have metabolic processes to allow these cells to thrive. So we know that these issues happen. Does everybody get diagnosed with the same packet of seeds? What are the differences in the seed packets that purchase?
Also, you may know that there are different types of breast cancer. If you've ever received a diagnosis, some patients have tumors that are called ductal carcinomas. Some patients have tumors that are called lobular carcinomas. Those are the two types that account for the vast majority of invasive breast cancers, SI2 breast cancers that we deal with. There are many, many other subtypes as well, but they're just not as common. And I think the face of cancer in general is changing. For the longest time, for decades and decades and decades, we really relied on the morphologic findings in a breast cancer, and we identify those depending on what we saw on our slide. So in the breast, the breast has a series of tubes. They're called ducts, and they divide and become smaller and smaller. And then at the end, we have what looks like a grape, and that's a lobule. And we have the tumors that arose from the ducts. And because a duct has a lumen, these tumors form these lumens. So they looked like they came from a duct. The ones that came from the lobule did not. It was a different type of tumor. And so we really relied on morphologic findings. Invasive lobular carcinomas often tended to grow in a single file because they didn't have this adhesion or this sticky molecule on their surface. So they tended to grow in a single file or as single cells, whereas ductal carcinomas had a sticky molecule, and so therefore they stuck together. That is now changing. We still obviously make that diagnosis in our reports, whether something's ductal or lobular or mucinous or whatever. But very often with the treatment of tumors, what is more important are the genetic alterations that may be occurring, particularly in more advanced disease. But still, the standard of care is we diagnose it based on what we see under the microscope, which is really the way it was done 100 years ago.
Can you give us just a couple of words on the immunohistochemical interrogation? Breast cancers are estrogen positive, HER2 positive, or triple negative.
So most ductal carcinomas and lobular carcinomas will be both estrogen and progesterone positive. And the way we look at that, it's actually relatively straightforward message, but there are receptors, both breast tissue, uterine tissue, ovarian tissue, and many others, brain tissue, bone tissue, has receptors for estrogen, both in males and in females. And the tumors, since they arise from the breast tissue, may acquire receptors as well. And so we test for them. And what we do is we have an antibody, which is a specialized protein that is directed towards estrogen. And we pretty much in the lab, we have this kit, we stain it, and it turns, if there is estrogen on the tumor, will turn the nucleus of the cell, the center of the cell, brown. And then we look at slide and we say, okay, here's an area of tumor, and what percentage of these cells have those brown signals in the nucleus? And then we give a percentage. So if we don't see any, we will say that's negative. It's less than 1% of the tumor cells, we'll say that's negative. If it's more than 1%, we'll call it, if it's less than 10, low positive. If it's more than 10, then we just come out and call it positive. And, so that's how we do both estrogen and progesterone. HER2 is a little different. That is not a stain in the nucleus. That is a stain that is in the membrane, but the concept is the same. It is also an immunohistochemical stain in which we are looking for the protein that is produced. And we are staining that protein found on the membranes of the cells, and we are looking for that and analyzing how many of those cells have that brown staining, and whether it is none, in which it would be negative. If there's some, depending on the setting, we would either call that negative or HER2 low. It has some staining, but not enough to make it outright positive. It's not strong, it's not diffuse, and we would call it equivocal. And then it has to be reflexed to a fish stain, which is a different type of procedure.
Thank you, Ann. Thank you. Dr. Plitas.
Yes.
Yes, you. We're honored to have Dr. George Plitas, who is on the breast surgery service at Memorial Sloan Kettering Cancer Center. He's associate attending on the service, but he doesn't just go into the surgical arena. He is also director of research for the breast surgical service. And I have to tell you, when you start thinking about not just what you are there to take out and make sure that it's all removed, but when you start thinking about what it is and how it lives and how it acts, and how our immune systems get involved when someone does have the evolution of a breast cancer, that's when you want to talk to Dr. Plitas. So, George, you and I have known each other for years. Unfortunately, I'm still older than you, but what can you do about it?
Why much?
Talk to me about when someone walks into your office. Tell me what goes on in your world.
Yeah. Well, it's often.
Is microphone on?
Can you hear me? Yep. It's obviously a very kind of scary time for patients, and usually the surgeon will be the first person that sort of starts to explain the process and the disease to the patient. And I think that interaction is critical. Because the scary time, it's scary for a lot of reasons, but mostly because you really don't know what you're up against. There's a lot of uncertainty. And you're meeting all these people and you're entrusting your life in their hands. And it's scary, right? And one of the things that's important to try to mitigate that fear and anxiety is education. And I feel it's very important that patients understand this disease at the level that we understand it so that they can then be informed, be less scared, and make right decisions for themselves. And along those lines, it's important to understand how we think about this disease. And we think about it in two ways, therapeutically. There's local therapy, things like surgery and radiation, and then there's systemic therapy. We very beautifully heard that the problem with cancer, any cancer really, is that it can spread from where it starts to another part of the body. And the reason why this happens is because tumors shed tumor cells and they circulate throughout the body. And like we heard, those tumor cells may not know how to do anything and they just die in the circulation. They could land somewhere and just stay dormant or sleepy for years and, a decade later decide to grow out. But in many ways, that is the most important phenomenon with cancer, because if something was to grow somewhere else, everything becomes much more difficult to treat. And so what we do up front to prevent that from happening is what truly saves lives. And so the local therapy is important to get that cancer out to stop future shedding. But more importantly, you have to address what's been going on already. And that's what the systemic therapy does. And in many ways, I always tell patients that your medical oncologist will cure this cancer. I'm just helping them along. So the systemic therapy is critically important. And that's where we've made incredible progress. And that's why women are surviving so long and are disease-free for the rest of their lives. And as a consequence of that, we can get actually away with less surgery, less local therapy, further improving the lives of our patients and the quality of life. So how do we figure this all out? Well, the local therapy, the surgery part, is pretty straightforward. We basically have to get the cancer out, and we have to sometimes assess what's going on with the lymph nodes. And mostly that's to help the medical oncologist pick the right systemic therapy. Sometimes we have a really good idea of what systemic therapy is necessary, and we might give it before surgery. So another thing that we have to kind of figure out in that first meeting with patients. And sometimes we give systemic therapy before surgery because we need that systemic therapy to shrink the disease so that we can get it out, maybe save the breast instead of having to remove it, maybe do less surgery in the armpit than we would have up front. Sometimes we get systemic therapy because we want to know the response, right? And so you get systemic therapy before surgery, then you have surgery and you know what happened. And in some cases, the disease is gone, and that's associated with good outcomes. Sometimes it's not gone, and that's less good outcomes. But then the medical oncologist knows this and is able to adapt accordingly and give adjuvant or after surgery systemic therapy in a very sort of personalized fashion based on that response. And so this all sort of happens at that initial visit. We just start this process. And it's very important that patients understand each step, why we're doing each step, rather than being told, just do this, just do this, just do that, because that's where the fear and possibly even mistrust sort of sets in. So this is what I do, basically, when I first meet a patient. I kind of lay this ground book down, set the expectations every step along the way. And I really do feel that creates a sense of empowerment in the patient. They've got more control over what's going on around them.
They become part of the team.
Yes, exactly. Very important.
George, I'm going to ask you a question only because it came in on the web. And I think it's really important because a lot of the research developed at MSK with Terry King when she was on the surgical surface looking at lobular carcinomas. Could you speak to the difference between classical lobular versus pleomorphic lobular? For a long time in my early career, I would see lobular cancer and say, "Oh, good, the lazy one.
Yeah.
Nothing to worry about. I just can't see it well on imaging."
Right.
But we began to understand over the past maybe 10 to 15 years, there's a pleomorphic subtype. And could you just speak to that a little bit?
Yeah. In general, there's a spectrum of, for lack of a better term, aggressiveness in breast cancer, right? And aggressiveness can mean a lot of different things. One thing it means is that these tumor cells in aggressive tumor grow faster and divide quicker than in a less aggressive tumor. And so there's this spectrum that exists. And historically, we relied on the pathologic evaluation of tumors to understand this. We look at them under the microscope, and depending how ugly they looked, they said, oh, okay, this is an aggressive tumor, a fast-growing tumor, versus this is a slower-growing tumor. Along the spectrum is a subset of cancers called lobular cancers, which we just heard of potentially originate not necessarily from the ducts of the breast, but from the lobules, the kind of breast that makes milk. And then these lobular cancers, some are slower growing or lazy tumors, and then there's a small rare subset where they're actually quite aggressive and ugly looking under the microscope. And so we call these pleomorphic lobular cancers. Pleomorphic is just a fancy way of saying they look ugly under the microscope. And they act differently. But these days, we actually have pretty good tests other than how they look under the microscope to understand their aggressiveness so that we can treat them in a personalized fashion. For instance, chemotherapy use oftentimes was decided on things like tumor size or if it looked ugly under the microscope. Well, these days we have better indicators for benefit of chemotherapy. One, for instance, is
For years and years, we had Peter Paul Rosen's paper on our desk in medical oncology, and if a tumor was just 1 millimeter over a centimeter, they all got chemotherapy.
Right. And so now we're switching to this idea of, well, maybe biology, not this arbitrary size, will dictate the need or benefit for chemotherapy. And there's this test that was developed called the Oncotype, and it generates a score. The score is validated in 2 big clinical trials now, and it tells us patients will benefit from chemotherapy. So if you look at the spread of Oncotype scores on this range of lobular cancers, you can clearly see that the pleomorphic lobular cancers tend to have very high Oncotype scores, and the classical lobular cancers have lower scores. And so pleomorphic lobular cancers are ugly, but they're treated differently. They chemotherapy, we now know the patients benefit from chemotherapy, and oftentimes they may not have the same expression profile of those receptors that we were talking about as classic lobular. So they can be too positive, or they can even be triple negative lobular cancers, where We even might give immunotherapy for them, treat them. So these days, other than just the way they look pleomorphic under the microscope, there's other biologic tests that we use to try to understand how we can treat them specifically.
Perfect. And you all in the audience are allowed to come to the microphone and ask question. If you're shy, but you're thinking of something, I promise you there are at least 20 others thinking the same question. I've gotten a few questions in through the portal that I will address today in various disciplines. Dr. Iyengar, I can tell you that 99.9% are going to be directed to you, so get ready. Thank you, George. Thank you so much.
Pleasure.
I'd like to keep in the breast surgical arena and introduce Dr. Lauren Rourke, who, well, I think we should switch shoes. Those shoes would look great with my outfit. They really would.
And you know what? Maria and I are the same size. So I better hold on tight or she'll end up leaving with my shoes.
Closet multiple times. In saying that, Lauren Rourke is a breast surgeon. And she's from Houston, presently. But she is someone who is known for her compassionate yet straightforward approach. She's empathetic. She can be funny, even where you would think, wow, how does funny happen here? And have a patient walk out actually with a smile, knowing that they're curable, they're treatable, we're in this together. And if you took note of a book that was on your chairs called Real Talk, Real Hope, Dr. Rourke authored this book. It just came out, I believe, in the late winter on Amazon, and she's already been interviewed by Fox News, so we're going to see her on the Kelly and Mark morning show and all sorts of other things. I'm not going to ask you about breast surgery. I'm going to ask you about the book. The book. I know the book. And I will say I don't think it's just for breast cancer. I think anyone who wants to build tools on dealing with information that's unexpected. My property got flooded 3 days ago. We lost all of our gardens and I learned something important. I'd better learn how to swim. So now I have a tool. But Lauren, you sat down with thoughts that led to the writing of this book. Please tell us about it.
Well, I've been doing this a while. I'm old too. I will say that, being in this field for 20 years, and I think George would agree, we are that first meeting with patients. And I've listened to so many stories and questions and concerns over the years. And when my mom went through her breast cancer journey, it changed me as a daughter, as a caregiver, and most importantly, as a doctor. And I wish I could say that our healthcare system works perfectly, but I think we all know it doesn't. It is broken. And the last 3 years, I started to get the nagging feeling like I needed to tell my story, that listening to my patients, learning from them, and watching my mom, there's information out there that I feel like every woman should have. And so nagging voice got louder and louder. I remember waking up one night and this tagline was in my mind, the club no one wants to join. And it stuck with me and it haunted me. And it is the club no one wants to join, right? Breast cancer. But having worked and been inspired with women who've walked this walk, there's something pretty special, though, about the membership to this club. And my patients always tell me, it's an elite membership. There is a bond there that's there for life with other women, with their family members. And so in my book, you'll see the club that no one wants to join. And then I got approached to write a book about something completely unrelated to surgery and breast cancer, but I said I want to do this one first. And I think when all the signs and all the planets line up, things happen the way they should. And even the cover, just for a second, the cover of the book is actually designed by a patient. and I'll never forget it. I was in the middle of finishing the manuscript, and we were at this critical 2 weeks that we had to design the cover. And if any of you have written a book, it's deadlines after deadlines. I mean, they're on you for everything. And when I got home that night real late, running the kids around, and it was at 11 o'clock at night, and I opened an envelope from a patient of mine, and it was a patient that happened to be a physician, and she had hand drawn and crafted the hand with the scalpel and a pen. And I remember looking at it, and I tear up now even thinking about it. I knew right then and there that that was the cover of the book, because I'm known for one, George and I use a scalpel. That's our tool. But the pen is my instrument with my patients. In every first meeting, I draw and I write a lot. And she captured that in one powerful drawing. And so, she will always be part of my story because she's the cover.
I love you. I love your shoes more. You're going to have an opportunity to take your books at the end of the program today, and Dr. Rourke will autograph them for you. And if you have any questions for her at that time, I'm sure she'll be happy to address them. Dr. Oles, I have to say that on one level, I'm so thrilled to work with you on a daily basis. On another level, I will tell you that when I bring up to any patient that I'm referring them to radiation, they yell at me. I've just finished my chemotherapy. Why do I need more? I just finished my surgery. Why do I need anything else? Dr. Tia Oles is a radiation oncologist. She's board certified, trained at the University of Syracuse. She's been with NYOH up in Clifton Park, and thank God, Patroon Creek, where I am in Albany, for a little over a decade, right?
I've been with NYOH 20 years.
Oh, well, double that amount. Double that amount. So, why do some patients need radiation therapy, and why do some patients not? It's all yours.
Complicated question. Forgive me, I haven't had coffee, so if you hear some syllables rubbing together here, just bear with me. That is a complicated question, and it kind of goes back to what we've already spoken about, the individuality of not only the person, but also the disease itself. Lots of things figure into whether or not you need radiation therapy. The simple answer is whether you had a lumpectomy, if you had a mastectomy, was there nodal involvement? Were there delays in your care? Were there questions after the surgery about margin status? There are lots of things that figure into that. There's no dry answer to it. We know historically that women who have breast cancer will benefit from radiation therapy in the context of breast conservation. The nuances of that go past what you would normally think if you have someone who had a lumpectomy that has a myriad of other health issues that take precedence, where they are looking at a situation where their longevity is really quite in question from other disease processes. You may want to really think about whether or not radiation therapy is something they should consider. The caveat to that is that there are shorter schedules for radiation therapy, so there are lots of things to consider. Every now and again, I'll mention a patient that I treated who lived on an island in Lake George, because that's a thing. And there's no direct way to get to their compound without boat. So this rather elderly lady that I was talking to about radiation therapy certainly needed radiation therapy. She did not need nodal radiation, but she needed something to be done to the breast. At the time, we didn't have a lot of information about partial breast treatment. That large study that was done and finally completed, we didn't have any data from that. And she actually wasn't interested in it, mainly because she knows how breast cancer works, and that we're talking about an entire breast versus lobule or duct, but I digress. In any case, she wanted treatment. She didn't want 6 weeks of treatment. This was a while ago before we had a lot of well-known hypofractionated courses, meaning shortened courses. So I did something that was a little unconventional at the time. We did 5 treatments to the breast at a dose that I really just had to do quite a bit of research to come up with because the data wasn't there at all, honestly. And she was so grateful because it took her an hour and 20 minutes to get to our office to go back home after, sitting in a boat for however long. I went through that very long and probably uninteresting story with you just to say that you are looking at individual people and their disease process and what they expect out of their treatment and what they want for their life, for their quality of life, because all of it matters. Something that Maria spoke about when she was talking about her early days in residency is everyone has a story. And I spend time trying to learn that story before I ever see a patient in my office, because that's important to me.
They're important for them.
It's important to it's the whole team dynamic because it truly is a team dynamic. So when someone comes in the room, I introduce myself. I will sometimes ask some questions because I want to validate what I've seen and what I've read in their chart, what I've read in their information packet that they fill out at the very beginning, because it matters. That person that has lupus, that's had lupus for 25 years, may not think about that as being a condition that I need to know about. But if I see Plaquenil or something like that in their medication list, I'm going to ask them. And then I may figure out, hey, that lupus probably isn't under great control. When was the last time you saw a rheumatologist? We need to get you to the rheumatologist because radiation is not going to be appropriate for you because that immunologic disease you have is going to prevent me from giving good treatment because you're going to have a lot of toxicity as a consequence. All of those things have to be balanced. And you can't ask the question if you don't know about it. You can't dig further into someone's history if you haven't taken the time to learn what it is. It is a group effort, it's a team effort. There's no on team. I throw that out there just because I had a personal trainer way back when who would say that to me all the time as I was sweating and wheezing through different weight training exercises. You are a team. Like, well, is there an ambulance outside? Because I need it. Anyway, I throw that up there anytime I can see, just because it sounds cool, but really it is a team dynamic. I can't help you if you're not helping me to help you. So I really try to create an environment where we are having conversation so that we can share the information. I don't know if I answered your question or not. I live on a stream of consciousness self-regulation. I don't know if I did or not.
Take podium and I can go home. That's what I. You did answer the question beautifully. I do have a question that came into the portal for you, Dr. Oles. And I think it's more, it's always a concern for whoever writes the question. And I think clarity is in addressing the question. A patient sent in a question about bolus in the setting of mastectomy that needs radiation because there were lymph nodes involved or the tumor had a close margin. For whatever that reason is, post-mastectomy to move towards radiation therapy to the breast to sterilize the areas. What does bolus imply?
Okay, so when we're talking about treating with radiation after a mastectomy, obviously we're looking at the area where the breast lived before because we're hoping to get rid of a microscopic disease that may reside on the chest wall where the breast was located. Understand that the concept of radiation in the post-mastectomy setting is really to address anything that might be left behind that was too small to have been seen on imaging or when the surgeon's there operating. I've spoken to surgeons over the years, and the best surgery that a surgeon can look forward to is that they don't actually visualize the tumor because it's enclosed in normal tissue and it's removed. So the only people that are seeing that tumor are the pathologists when it gets to the lab. So radiation in that sense is really a preventive measure. It's kind of a clean measure because the hard work has been done. Local control is important, so that's why it's not neglected. Bolus is actually a physical entity, and it's placed on the chest wall because you don't have a breast anymore. Now, instead of having a breast as a target for the radiation, the skin is the target. The soft tissue is a target. Because if there are cancer cells remaining on the chest wall, that's where they're going to be. So the bolus actually allows that dose of radiation to make it to the skin itself. I will not bore you with the physics of radiation, but I will tell you that there's a space that exists where you do not get the dose yet. It's a physical space. It's small, couple millimeters. But if you neglect to make up for that missing space, that means you're sparing some of the skin on the chest wall, i.e., you're sparing some of your target from getting total dose. So bolus makes a difference when we're looking at dose distribution. Forgive me if I'm putting any of you to sleep. I am trying to make this somewhat interesting. When we talk about radiation therapy, we're always concerned about the dose and the percentage of the dose that's getting to the area it needs to. We are obviously concerned about normal organs in the area that we're treating because they're just as important. I haven't done you a favor if I've caused you irreparable harm, but I cured your cancer. I got rid of anything that was left behind. So there is a balance. It is unacceptable to have dose to the skin in a post-mastectomy person. That's less than 70%. And that's what you end up getting the majority of the time if you don't use this physical material called bolus to lift the dose up to the skin. So there are some institutions that don't use bolus, but typically those institutions may not use it because of the person's body habitus. If your chest wall is more than, I don't remember the exact number of millimeters, forgive me. No, it's actually centimeters. If your chest wall is less than 4 centimeters in thickness, you actually don't need bolus because that electronic equilibrium point is actually so superficial because of your depth tissues, you don't need it. But 4 centimeters may not sound like a lot, but that's a decent amount chest wall. So the majority of people are benefiting from bolus. And if you're wondering whether or not that's considered during the treatment planning process, it actually is. When the magic happens, that's that period of a week to a week and a half after the treatment planning session, when the dosimetrist and the physicist and I are sitting down coming up with the best possible treatment plan. We look at a plan with bolus and without bolus. And inevitably, having the bolus gets a higher dose to the skin, which again is the target. The difficulty with that when you're receiving treatment is your skin is the target, your skin is getting red, it's getting irritated. So that target is also something you are physically aware of every day that you're getting your radiation. Every day that you get further into your course, you're noticing it's pink, it's red, it's irritated. You get this prickly heat rash that's itchy and burning all at the same time. And you're wondering why it's progressing. It's because it has to progress because it's target. That's not a really acceptable answer, but it's true. There's really no way to get good dose to skin if you aren't getting good dose to the skin. So that's what bolus is. It really is a physical material.
Thank you, Tia. Another question that came in, and this is for Dr. Pledis and Dr. Rock. And you can prefer, that'll be your not going to get $1 million, you can confer. Patient writes in the same setting, I've just had a mastectomy. Why would I need anything? There are no more breast cells left behind. So take it.
I think we're going to say the same thing.
Yeah. There's this pathologic entity, which is something called lymphovascular invasion, where you have a mass of tumor cells, and then if you look at the surrounding tissue, even the skin, you can see isolated tumor cells scattered about the tissue. And those tumor cells can actually extend all the way into the skin. They can extend into lymph nodes farther away from the surgical field, and they could be a nidus for a local occurrence down the road. And we can't remove all the skin. We can't remove all the lymph nodes, some of which extend deep into the chest. And even when we did try to attempt that, it didn't actually make much of a difference. That's what radiation gets to. Radiation gets to those things that we physically can't. And there are some people who don't need it. And we're able to sort of risk stratify people based on the stage, so how big the tumor was, whether or not there was lymph node involvement, some pathologic features, to try to understand who is at higher risk of local recurrence. who's at lower, and then treat accordingly with the radiation. But at the end of the day, the radiation really kills the tumor cells that we just can't get to.
And I'd just add, we as surgeons, when we do a mastectomy, we remove all of the breast tissue we can see, but we cannot see cells. And so I always tell patients, there are breast cells left behind. We see the tissue we can see. And so, that's why radiation and surgery are good partners when needed.
Wonderful. We're going to take the last 15, 20 minutes of this session to actually focus below the waist. And I'm actually going to ask and abuse Dr. Jean Carter, if you'll come up. Yes, I'm going to abuse you twice today. I'd like to introduce, and thank you so much for being here, Dr. Tana Bradham. She is a gynecological oncologist who is at New York Oncology Hematology, who was kind enough to come in when Dr. Heidi Doy could not make it today. I will say, Tana, I'm getting rave reviews about all the patients that are seeing you. So sometimes we need a pat on the shoulder, and you've got one on each shoulder. Okay, thank you. Thank you for what you're doing. And Jean, Dr. G. Carter is a clinical psychologist and certified sexual therapist, and she provides individual interventions for women with cancer. She's the chief of the division at Memorial Sloan Kettering Cancer Center. And I just wanted to make sure that when Dr. Pradham is talking about her patient population, that I'm not going to be dragging you up here. So just have a seat and be comfortable, okay? Tana, so many patients that are diagnosed with breast cancer come back to the surgeon and come back to me, and they say, well, should I have a hysterectomy too? Should I have my ovaries taken out? Will I live longer? And I'm sure you get that a lot. Can you talk to that? That was one of the questions that came in.
Yeah, thank you. The question. I think obviously we always have this intuitive connection that the gynecologic organs and the breast are inherently connected, and it totally makes sense, right? From when somebody's diagnosed and they're just like, okay, I just want it all out, because they'll come to us and they're like, I just want it all out. And so we kind of have to parse out exactly, what's going on with the history. Certainly one of the biggest things, as we know, is genetics, right? For those who are undergoing testing, if we have a patient that does have a BRCA mutation, then that's certainly a discussion for surgery, where we talk about removal of the tubes and ovaries. Again, anatomically speaking, the tubes and ovaries, it's all connected to the uterus, but that doesn't necessarily mean that we have to have a hysterectomy. And so when people come in the setting of, say, genetics, and it's indicated and we're doing a oophorectomy for that, we'll talk about a few indications. Certainly for any woman who's had, apart from a breast diagnosis, apart from a genetic diagnosis, if there's fibroids, if there's abnormal bleeding at baseline, if there are any other gynecologic issues at baseline, then that's kind of a no-brainer. If we're going in, removing tubes and ovaries, yeah, we do that all together. We often do that in a minimally invasive fashion, often laparoscopically or robotically, where recovery from hysterectomy is not as bad as people tend to think when they walk out of our office after counseling. They're like, oh, okay, it's not bad, and they tend to do fairly well. But, that's sort of one thing. The other thing, there's some older data to suggest, if we look at large populations of women, there's a slight increase in uterine cancers with BRCA patients, but there's been no, from a slightly increased incidence of sarcoma, but there's been no definitive data on that. So I'll counsel patients in a BRCA setting that, what else is happening in your GYN history, and with this small increase, do you want to go forward and have more surgery? Because certainly more surgery is always more risk. And for a woman who's not, if the genetics is negative, we don't have any concern about BRCA. Again, it just goes to other gynecologic conditions. Is there any concern, bleeding, fibroids, etc.? And lastly, I think the other indication for a hysterectomy is really the endocrine management. So, as I'm sure we'll be touching on various points of this conversation today, with endocrine therapy, and especially women who are on tamoxifen, if there are any issues, bleeding, intolerance, etc., then that's also a large percentage of patients that we get when we're talking about a hysterectomy per se. I think that's the hysterectomy portion. Yeah.
So a patient is carrying a genetic mutation, whether it's the BRCA1, BRCA2, BRIP, whatever, and they're referred to you for prophylactic surgery. All right. And what do you discuss with the patient prior to the surgery insofar as their expectations post-op, especially when they're only 35 or 40 years old?
So I think the first thing is that, when we have somebody with these genetic mutations, we have guidelines, because the question is, when is really the right time? So we have guidelines to say, okay, BRCA1, BRCA2, what is the age range? But every woman is different with respect to what's happening with fertility, what's happening with their family, right? And so, we do have screening, for lack of a better term, for high risk, where we do the combination of, ultrasound exams, CA-125 monitoring. I mean, just continued, surveillance. But I think timing is really essential. People think that there's just this magic switch that, okay, I'm 35 and I'm BRCA1, I have to have my ovaries out. Well, it depends, because, fertility is a huge question. So we definitely want to make sure we address fertility issue. Secondarily, it's, understanding out premature menopause and going into surgical menopause. What's the plan? Because I think it's very difficult to go ahead and do the surgery and then deal with the side effects without having that counseling, right? So we do talk about what are the options. If somebody obviously doesn't have a personal history of breast cancer and we're doing this prophylactically, then we have some options, right? We can talk about what replacement would look like. And we talk about that early and in the beginning, because we don't want to wait till afterwards and not have that expectation. And
Can you speak to also the black box removal from hormone replacement therapy in those patients who are not diagnosed with breast cancer?
I think that there's just been, I guess what I can say about, there's just been a lot of fear and uncertainty about, about the data, about old data from, from the WHO study, which, I'm sure all these folks can go into it a lot more and slice and dice it than even than I can. But needless to say, that black box warning comes from, some data from a study that is older, had different type of hormone than we actually use now, and in an older population, where now we know we want to start earlier. And so I think with that removal, I think a bit of a veil is lifted. I think it's just more, now in the education of our folks who are in the medical field to not be as afraid. So yeah, I think that has actually helped in our counseling, and especially for women coming in situations that we're just talking about now.
I'm certainly going to address in the fourth panel the issues of hormone replacement therapy, as well as the new information that's come out regarding progestins versus estrogens, the pros, cons, combinations, singlets, what's appropriate for a postmenopausal woman, what's appropriate for a young woman. And again, the caveat is if somebody has been diagnosed with breast cancer. Jean, I kind of have you up here as a fail-safe for me, but you see these patients. You see the patients that go through prophylactic surgery or surgery for a reason. It could be a GYN surgery, which I would like to address in a couple of minutes. And do you find that, I think it's an unmet need, so I'm going to prejudice it. Do you find that you're getting referrals from providers who are often busy, seeing 20, 30 patients in a day, have given maybe bad news? Do they take breath in a tertiary center like Memorial Sloan Kettering Cancer Center to say, well, part of your your team is going to be your service. We kind of touched on that dinner last night. So
are you talking about it specific to the risk population?
can you hear out there? Okay.
Because you're talking specific to the high risk population. Obviously, one thing that we didn't mention was there are a lot of women that are now choosing to do sepingectomy, which is just removal of the tube and then to have your ovaries removed later. And there are two huge trials. The WISP trial looked at that, and they found that obviously women did better from a sexual function standpoint. And there's a huge cooperative group trial now going on, SOROC, which is hoping to answer more of these questions. So I think that the voice of women has pushed the medical field really to look at different opportunities and compromises so that they can not experience some of these acute side effects of menopause. So if I'm seeing someone in regards to that with high risk, a lot of times the doctors are comfortable, and please forgive me because they would come to you and talk to you about this. So if I say anything correct, feel free to correct me. But taking out the ovaries and doing a supplementation of HRT will be much lower than what they thought perhaps they were having. So in that particular population, HRT is a very reasonable conversation and does have many other health benefits. It may not be enough to translate to the vagina. So we do talk about other options. We have a lot of data to support non-hormonal strategies, which work quite well if women get the education about what to use, where to use it. I'm hinting at vulva. I'll talk about that later, but everybody forgets vulva. And at a high frequency, because these treatments that are over the counter are really for women going through a natural menopausal transition. And that's not what our ladies experience. It's a drop off. And of course, low dose vaginal estrogens, again, with the blessing of the medical oncologist in a cancer population, can be used very safely and reasonably. But again, it's just having these conversations and talking with patients and making sure that they have information so they can ask the right questions and that we understand how to bring it up and offer solutions as well.
Yeah. And I think, Anna, with your interest in developing a survivorship program and addressing a lot of these unmet needs up in this part of the world, I think going to be huge. I applaud you. And there to back up in any way you want. I think it'll be important for all of us in medical oncology, surgical oncology, and just for everybody who is a community participant, whether they have cancer or not.
I would just give a plug because I think when we create these formal programs for survivorship, it really does create more equity for the population. Because, obviously there are some women who are lucky enough to advocate for themselves, who recognize symptoms or early stages when they're in perimenopause, when they should be, starting to seek care and treatment. But not every woman, is able to do that and to have a voice for themselves. And I think by creating these formal programs with criteria and pulling women into, just a survivorship visit, a formal visit where we do go over very specific things and screen for things, I think that's really going to take care of our population better.
What saddens me are the women who are knowledgeable, who are in tune with their needs and their body, and then don't have facilities, don't have the program, don't have those needs met. And that's what we really have to strive for up in this part of the world, in the Hudson Valley and the Capital District. It's long overdue. So with that, we're going to take a break. I thank you all for being out here. Obviously, I'm going to abuse the two of you a little bit more. So thank you, Dr. Pletus, so much for being here. Dr. Rourke, I think your book is going to be a smash everywhere. Can't wait for number 2 and 3. Tia, just adore you. You make scary things so unscary. And if you ever retire, I'll be retiring the next morning because I need you for all the patients that I see. Tana, we're going to be in the next session together, Jean, this afternoon. Although I'll probably put you up for the next one too. So everybody take a break. Let's be back here. Give them a good round of applause. How's this working, this forum so far? Hey, good. Okay. So let's take a break and be back here at 10:41 so we can start 10:45. Okay, thank you. Well, while everybody's being seated, I'm going to ask you to pay attention to the pictures that are up behind us. Here we go, right, lefting. I'm going to get into trouble. So the picture on the upper left is a young woman who was diagnosed with a HER2 overexpressing breast cancer at the age of 24. And she was looking forward to her wedding, but she needed to be treated first because of this very aggressive subtype breast cancer, which we're going to discuss in the present session. I treated her, and you can see that she lost all of her hair, but she also got rid of all of her breast cancer. When she went to surgery, she had a past CR, which means we couldn't find any cancer cells in her breast or her lymph nodes. Applaud on that one. She got married, and she refused to wear a wig. And you can see her here in her bridal gown with her bridal party. Very excited. And she went on an anti-estrogen therapy after she completed her anti-HER2 antibodies. And she said to me what all young women say who have dreams and magic in front of them and a husband that they're in love with, a partner they're in love with. When can I stop these pills to have a baby? Ouch. You know, it's one thing that we've all encountered in our practices, and For the Promise trial gave us some support stating that, yes, patients who are estrogen positive, who have completed 2.5 to 3 years of their endocrine therapy, can take a pause, have a baby safely, and then resume their endocrine therapy. And I will tell you that since that publication, several babies have been born, and on the, I guess that's the right, you can see that her husband is holding a young child. They named her middle name Maria, which made me cry. And then I said to her, well, you're living in Maine now. You have to see the local medical oncologist to resume your tamoxifen. And she said to me very quickly, I'm pregnant. Please let me have another baby. And there you see her second little baby, who's a lovely little girl. And there is life. There's life. And there's a drawing right underneath that I think is just, when I first looked at it, it kind of knocked me backwards. When you look at this piece of artwork, I've got to be careful not to speak to the painting is called And So It Goes, and it's by Drew Lost. Who, Drew, are you in the audience? Can you stand up safely? This is Drew. Drew came to me less than a year ago when she moved up to this part of the world from Memorial Sloan Kettering Cancer Center. We said it was okay to talk about this. She is 27 years old, or are you an old lady of 28? Okay, an old lady of 28 with metastatic breast cancer to her bony skeleton and treatable. Get that? Treatable. And when this was painted, she had just found out that she had advanced disease, and this is how she felt. And I thought it was such an outstanding piece of work that I asked for her permission to, I think it's on the back of the program here. Here it is. Okay. And I thought it was very inspiring because where we all fall short, I say it with all respect to people that I love on the stage, where I fall short is that, yes, we're compassionate, we're caring, we want to do the best for our patients, we want to listen to their voices, we want them to hear our voices. But in a half hour, we have a new patient. And now we're redirecting. And then we go home and we have our own life issues and we're redirecting. But all of that is going on in the patient that we saw earlier that day. And we have to find a way to make the beauty of that the beauty of their lives. And Drew, thank you, darling. All right, thank you. So with that, we're going to move to the second panel discussion. I got emotional. My mother told me I was not meant to do this for a living. She said, you should be delivering babies. I said, but then I would have to take them home. So it doesn't make any sense. So I'm going to start by introducing Dr. Hyman Muscle, because you're right next to me, who I have to say, I consider a dear friend. I consider one of the medical oncologic thought leaders and champions. I consider him a mentor and a teacher, but I'm happy to consider him a friend. And Dr. Musk is a professor of medicine at the Mary Jones Hudson Distinguished Professor of Geriatric Oncology and Director of Geriatric Oncology Program at the University of North Carolina. Multiple awards, multiple trials, grants from the Breast Cancer Research Foundation. And by the way, we have Maya Biblowit here. Is she in the audience there? Could you stand up and say hello to everyone? Mara is the President Emeritus of the Breast Cancer Research Foundation. I think last count, they granted awards, I think upwards of $70 million for research that's going to help cure Drew. So there we go. Dr. Musk is one of those recipients, and we'll hear a lot more from him during the last panel, so far as how we approach patients that may have comorbidities, what our research should be directed to, when do we say enough is enough, and when do we say let's move forward. And so I'm really excited about both panels. Dr. Chao Dang, her name is recognizable around the world. She is a medical oncologist, and she is one of the senior, not the old one, you're the young senior, medical oncologist on the breast service at Memorial Sloan Kettering Cancer Center, has been at the forefront of HER2 research, HER2 new trials, data coming to the forefront, which has saved patients like a 32-year-old that I met when I was a medical student. And I will say that she also has extended her passion to what happens after we treat our patients with all of these medications. What about the heart? How do we follow it? What should we be cognizant of? And so we're going to hear a lot more from Dr. Dang. Dr. Iyengar actually has a tunnel from Atlanta coming all the way up here to Hudson, because he's basically at every single program, as well as Dr. Dang, as well as Dr. Mudd and Dr. Arena. I guess that's it. You're all here all the time. Dr. Iyengar is at Emory University School of Medicine. He is now at the forefront, your co-chief, correct, of the breast medicine service in Atlanta. He's the director of survivorship services. So Tana, listen to all the survivorship that you're hearing, okay? These are people you need to speak to and develop a program for us up here. He is the Director of Survivorship Services at the Winship Cancer Institute at Emory, and certainly a member of the Winship's Glen Family Breast Center. Um, but more importantly, he dives into the breast cancer cell as well as the human metabolism and look at metabolic influences, has authored and has researched obesity and its risks associated with breast cancer occurrence and recurrence. He's looked at the behavior of the cells when it comes to insulin and glucagon, and we'll talk about GLP-1s at the last panel. Hold those questions during this one, but kind of really gets it. And I think you'll all be thrilled to hear him speak. All right, the guy in the middle in blue, sitting there like he owns Hudson Hall. Are you wearing your pocket kerchief? Yes. Isn't it amazing? I love it. I went and bought my husband 5 pocket kerchiefs, and he thought it was to wipe his brow. But Frank Arena is one of my best friends. I've known him since I was an intern. When I met him at 2 a.m. in the morning, this is pre-Bell Commission. We're doing 36 and 40-hour shifts straight on. And I was on the oncology ward. And at 2:30 a.m., I got tapped on the shoulder. I was startled because it was kind of quiet, except for the beeping of all the machines that everybody was hooked up on, and complimented me for the way that I was working with his patient. And when he left, I said, it's 2:30 a.m., and this physician, like all other physicians, should be in bed, but he came in to check on a patient that was just admitted, which tells you something about who Dr. Arena is. And he is a medical oncologist associated with NYU. He is head of the Arena Advocacy Foundation program in Long Island. He treats all malignancies, but a good, I would say, maybe 75% are breast. He has grant awards for research through his foundation. He is a pioneer in communication, and he just told me his book, Reflections of a Breast, and if I'd known I would have had it up here, is due for a skin printing. He has gone back and researched the history of breast cancer. It is not a new disease. I think Rembrandt's Mistress was painted in 1654, but you have one that predates it, 1,000 years BC. 3,000 years BC was the first breast cancer diagnosis. So we will have Dr. Arena come back to give a lecture on his reflections of the breast. We'll buy 300 of his books and have him sign them. And just a wonderful teacher and a compassionate caregiver. What can I say about Ranjit Banwait? I know him this much, but what I do know is that he's going to carry the baton and the helm of breast cancer up in this part of the world forward. He is a board-certified internal medicine and bariatric medicine oncologist with a deep focus on breast cancer. I'm sorry. He joined NYOH just recently, about a year ago, coming from San Antonio. I had dinner with him last year prior to the CME accredited breast cancer program that I'll be hosting again next year. And I was so impressed with his depth of knowledge. And it was kind of like the old doctor who still wants to write her notes looking at artificial intelligence, and that's where it is. So looking forward to all the new roads that are going to travel with Dr. Banwait. And Rana, what can I say? I'm just so glad you're back with us. And your role actually is going to be interesting because all these 5 medical oncologists medically castrate patients all the time. And so there might be a few minutes where you could address some of that. So one of the questions, we have several questions that need to be addressed, but I'd like to be able to talk about early breast cancer as well as advanced breast cancer. What's happening today? What's happening in our world of research? How are we changing the way that we practiced even 5 years ago, even 3 years ago? And because breast cancer is so heterogeneous and it's multiple different diagnoses under one umbrella that's called breast cancer, let's take an estrogen positive breast cancer patient that is HER2 low or HER2 zero. She's had her surgery with Dr. Rourke or Dr. Pledis. She comes to us and she has a stage 0. She has a stage 0. What does stage 0 breast cancer mean? Ranja, can you take that?
Stage 0 breast cancer. Wow, that's usually the long consultation, the longest one, because no one really understands it. But I think there's some misnomers that we first need to correct, which is that, is this a precancerous state? Is this a cancerous state? Then why is it stage 0? So my consultation for what we call carcinoma in site 2, which is considered stage 0, it starts off with that. It is a cancerous state, but it's not as invasive ductal carcinoma or lobular carcinoma. So I think clarifying that definition, and a lot of this is probably, as Dr. Pledis had said earlier, that empowering the patient with knowledge so then they can carry forward and make the right decisions for themselves. So hearing it for maybe the second time, third time with me, it kind of sinks in a little bit that this is a cancerous state, but perhaps it's not the metastatic state or stage 3, stage 2. And perhaps maybe the management is a little bit different than what we would do for invasive carcinoma. So it starts off with that. There's a little nuances to it.
So there are several questions that I'm hoping that you'll all support in trying to answer that came through. And it's basically the same theme. Patient who was diagnosed with ductal carcinoma in situ, and it was a moderately differentiated grade 2, ER positive, totally removed, marked as negative, had radiation therapy in the setting of breast conservation. And the question that comes in is, do I need a PET scan in order to make sure that the disease is not anywhere else? Any one of you? Do I need a PET scan? Dr. T, can you order a PET scan for me?
I would say no. Sorry. I would say no. First, stage 0. There aren't many cancers that we treat with stage 0, right? So it's an anomaly in breast cancer. And a lot of scholars now, and a lot of breast cancer experts want to change the name and call it pre-cancer because it petrifies women and petrify me and the few men that get it.
Yeah, and that ductal carcinoma in situ, that carcinoma sticks out and the patient is terrified.
And it rarely ever spreads. And when it has, they're old studies, not with modern therapy. So it's a scary thing, but it's not, it's a little different. As far as a PET scan, that's to look for metastatic disease. And here, the chances are so slim. I would never recommend it. And the other thing about these scans, they're not perfect. To find a cancer, it has to be about the size of a marble or smaller. So you can have millions of cancer cells. Any of us on the panel could have it, and the PET scan is not going to show it. And then the other thing is occasionally it shows stuff that's not cancer, and everybody's panicked, like little benign tumors, little cysts in your liver, and you end up going on a wild goose chase that scares you to death, costs you thousands of dollars, and at the end, you're no better off. So I would never recommend it here in a stage 0 cancer. And maybe some of the other colleagues might want to even talk as a routine follow-up, even with an invasive breast cancer.
So let's take that one further, all right? And I will say that we have to change the name of DCIS, ductal carcinoma in situ. It causes more fear. And it takes quite a bit of time to explain to a patient that those seeds never got past the soil. They never went past the soil to spread their seeds to other places. And it really is a scary thing. And drawing pictures and trying to define it, patients are often happy because they come to me after surgery with the idea that, am I going to need chemotherapy? Do I need a PET scan like this woman wrote in? Fred, please.
No, I think it's close. Can you hear me now? Good. I think everybody needs a PET scan. Everybody, you too, me too, everybody, right? Why not? In Long Island, where I come from, where more is always more, there used to be in strip malls everywhere you could see scanning places, just like, next to McDonald's, next to Target, whatever. There were these scanning places, and they were full. It was like, you had nothing better to do on Saturday afternoon, go get yourself scanned. They all closed down. They didn't close down because they, A, were not making money. They were making a fortune. B, it wasn't because they weren't finding things. They were, but they weren't finding cancer. You see, a PET scan does not equal cancer. We got to get that out in the open. It doesn't equal cancer. You're looking at the metabolism of sugar. And anything that eats sugar is going to light up. Inflamed, infected, autoimmune, inflammatory, yes, cancer. But it has to join that whole group. So to say to someone, you need to get a PET scan, let's go fishing. I don't see it. But it's in this consumptive type of philosophy that we have sort of come to, that more is more. We need to get more. And yet we have to look at the rationale behind everything. I just want to bring out something. What is old is new again. The original name for DCIS and LCIS was cancerous states. There was change roughly, was it about in the late 1960s, early 70s, but
HAs.
yes, they changed the name, they're going to change it back. Because it scares the behemoths out of people. Really. Your conversations with people, half of it is just to get over the word cancer. Nobody dies of DCIS. Let's make that clear. Nobody dies of LCIS. Nobody dies of ADH. The answer is it's a marker. It tells us what's happening. It gives us a clue. And you work on those clues to find the golden sombrero. It's always that. So in my mind, you don't go ahead and do PET scans on people unless you know what the heck you're looking for. It's not a fishing expedition. We're not just trying to see what we find on a Saturday morning here in Hudson. We're trying to figure out what it's supposed to be. You're supposed to know what you're doing. You're looking for something, not just find it and then I'll figure out what I got to do.
So a question came in, and I'm going to read it verbatim. And I think, Chow, you've spoken on this in the past at one of the programs for physicians. This woman writes, based on the latest research and the continual sneaky pattern and behavior of lobular cancer, and this is something we can all explore, what types of scans detect reoccurrence best, and how often should someone be getting them? How is it treated differently than ductal when it comes to monitoring? We don't know the stage here. Okay, we don't know any other details, but if you could take that.
Can you hear me? Thank you. Thank you, Maria. So lobular cancer, as our surgical colleagues spoke this morning, are tricky. I mean, they the glue, so the cells don't stick together and they line. So after surgery and radiation and therapy that we give, systemic therapy, much of it is anti-hormonal therapy, anti-estrogen, to prevent recurrence, to prevent the seeds, I call it the dust. The dust, there'd be dust in your body that could feed off of estrogen. So you get anti-estrogen, so that those cells, the dust particles die. But the question is, how do we know when there's a recurrence? That's a tricky question for, I think, breast cancer, regardless whether it's lobular or ductal. Our cancers go to what I say, the B's and the L's, bone, brain, lung, liver. So how do I know if a patient has a recurrence? We actually don't know, unfortunately. We wait, we listen to symptoms very carefully. There's treat symptoms, the menopausal symptoms, and there's cancer symptoms, and what are they like? So we're always listening for that. And maybe it's like having something in the bone hurts. The question asked by our patients that, can I get a scan? I get a scan of lobular cancer. I worry it's come back. And I listen to symptoms, and the patient is doing great. So I just say, I don't know what the scan is. And again, the PET scan won't be able to see it. We have a fancy scan called an FES scan that's looking for that estrogen. But if it's dormant or it's silent, these scans are going to be negative. So unfortunately, when we're following our patients, as our patients are surviving, thankfully, we're listening for symptoms. So there isn't the right scan. But if the patient becomes metastatic at some point, and we know they're metastatic because somehow we found it one way or the other through a biopsy, and it showed in the patient lobular. Sometimes a PET scan might show it, sometimes, but oftentimes it doesn't. And this is where we use a special scan, the FES scan, to help us find those estrogen-feeding cells to help us. But I have to go back, Maria, before we had these fancy scans, how did I monitor my patients who had lobular?
There was a wonderful paper that was written when I was a rookie about how we follow patients for recurrences. Should we be imaging everyone? Should we be obtaining tumor markers in everyone? And the bottom line with what you just said 2 minutes ago, it's listening. It's usually the patient telling us something that leads us to an interrogation, an investigation, a physical exam, but it is what the patient tells us. That's right. The number one way of being able to say, let's just make sure XYZ is not going on. And nothing has really changed to up that. And in a stage 0, absolutely no imaging whatsoever. We don't have a cancer there. We really don't. Stage 1 depends on the stage 1 and what other factors may be presenting. But honestly, unless somebody is a stage 3 or a node positive stage 2 of a young patient, there has to be a rationale for obtaining imaging. It just won't show up. And it's not, for me, 100% reassuring. My PET scan came back fine. I only had 2 positive lymph nodes. Nothing showed up anywhere. So I don't want chemotherapy. I don't want anti-estrogen therapy. That's not what's going to guide us in recommendations on how to increase disease-free survival. That means how long somebody will live without recurrence, and certainly overall survival, how long a patient will live, period. So we have to use some common sense. Yes, Dr. Arena.
Are you right? We have a new toy in our box. We have a new toy, and that's circulating DNA. And I think
that's the next question. Perfect.
You told me that last night ago. What the heck is circulating DNA? Does anybody know? I don't know. I'm trying to figure that out. But if I use my favorite analogy of puppy dogs and kittens, I think if everyone has had a puppy dog or kitten or know of one, you know that they shed hair. You don't see it until you take your vacuum cleaner out or your broom and say, oh yeah, they shed hair. Well, tumors shed hair. They shed DNA. And now we have an incredible tool basically on a simple blood test that costs a fortune, but it's a simple blood test. And we haven't seen the last of this. This is going to come into prime time like no other business. There's even a blood test now for looking at circulating DNA to make the diagnosis colon cancer. PS that's coming for lung cancer, that's coming from breast cancer. Stay tuned. But again, you have to use judgment who you even order this blood test on. It's not going to work for stage 0. It's not shedding hair. There's no hair to shed. Stage 1, if it's a stage 1, unless it's really outstanding circumstances, probably not. Stage 2, yes, if they're nodal positive, maybe we could look. I think the criteria stage 2 and 3 are, of course, stage 4. But that is going to be, we're going to hone in on this. This may be the new toy in the chest that's coming out and everybody's going to scream about. And it's not an x-ray, it's not a PET scan, it's a blood test.
Although it's sobering because I have a patient with stage 4 disease, including the CNS, and Signatera was negative. So again, I think it's going to be very useful in advanced disease. I think it's not a standard of care at this time in early stage disease. It may become a standard of care. I'm enthusiastic about it being incorporated in clinical trials so we understand things better. But unless there's a full trial, peer-reviewed benefit, I'm right now using it only stage 4. What about you, Neil, at Emory?
I think that's well said. So, I think we're at a really exciting time in early breast cancer in terms of the research, both in terms of diagnostics as well as in terms of treatments. It's certainly circulating markers like ctDNA can be helpful in certain circumstances, but we're also starting to go back to the basics now that we have better tools like AI. So there are a lot of studies that are going on right now that are analyzing whether or not you can look at slide from the breast tumor that was removed from surgery and use histologic or pathologic patterns under the microscope to then predict, will that tumor respond to chemotherapy? Will a tumor respond to various molecular therapies? It has to do with the fact that we have research databases now for several years that have collected circulating tumor DNA in a variety of patients who have volunteered their blood graciously, from those patients who have stage 0 disease, where we learned that circulating tumor DNA is not helpful because of the lack of shedding, all the way to stage 4. So now we're in the sort of era where we can use these large data sets of molecular data from circulating tumor DNA, but also molecular data from the tumor itself and the slide under the microscope, and put together old technology and new technology to emerge with an even deeper understanding of how to optimally treat breast cancer. So it's very exciting right now, and the pace is just accelerating. I don't know if that answered your question.
No, but please go ahead. Yes, it does.
You just want to share an experience, I think, from a community perspective, right? So I think every other day, I'm fielding this question about ctDNA. I think in the community, patients know about this testing and they bring up this in the conversation when I'm seeing them. For example, I had a case the other day, taking care of the patient who's up here in New York for the summer months. She's from Florida. The oncologist did order ctDNA, early stage, there's no indication, it's not approved yet, but she was paying out of pocket because it's not approved by. So, I mean, look, this, ctDNA, and I look back at the historical data, it's been flat, and slowly but surely it is trending upwards. A PET-CT was done, as we just discussed, possibly didn't need. Nothing was found. So she's up here in New York, and anxiety is off the roof. I have nothing to offer at this point. So I think this is a challenge in the community, and patients are asking about it. So looking forward to the research that we get.
Those challenges that we confront in the clinical room in that intimate setting are difficult, and oftentimes we may not have an answer at that moment, but it is our duty, it's our burden, it's our privilege to explore, interrogate, tease out everything that we can for that individual patient, the way we want it for our own family members, for ourselves. But we won't always have the answers. But all those questions are leading cancers. And I'm going to flip right back to you, Chow, because I remember in 1994, I was the PI on the first HER2 anti-HER2 antibody treatment in a salvage setting, single agent, when we didn't know anything about fish. That didn't even exist at that time. And since then, since understanding the particularly aggressive subtype of breast cancer, does the audience know what HER2 is? All right, so I'm just going to do something real quickly because we have a few minutes. I'm going to take this first one right here. Okay, get ready, ladies and gentlemen. Okay, if I were to ask Dr. Rourke to raise her right arm all the way up into the air, okay, and Diane, you raise your left hand all the way up in the air. Without moving from your chairs, can you touch hands? Try. Come on, let me see some energy. They're waiting for the lunch hour. Okay. So this is a normal breast cell with normal HER2 expression on it. It's there. It's really not functional when we mature. And those proteins are on the surface, but they don't touch each other. Now, if I were to ask, I'm sorry, the light's in my eyes. Lauren, George, raise both your hands. Both. George, take the phone out of your left hand and raise it up. Mary, raise both hands. Diane, both hands. Now can you each touch each other's hands? Now these are excessive proteins on that subsurface of HER2. And in breast cancer, those touching hands tell all the pathways can tell the cell to multiply and never die. So that's a HER2 positive cell. Did I do okay or did I confuse you? Okay. No, it's okay. And the antibody that was first explored and first came in to the clinic arena because of advocacy groups, patients fighting for it, back in the early 1990s was Herceptin. And if Lauren and George can raise both hands, and then the gentleman with the eyeglasses had off his shirt in the second row. Yep, you. Take your hand and separate their hands. Go ahead, don't be shy. Don't let those hands touch. That's the antibody. It stops it from telling the nucleus to multiply. It's all yours.
I have nothing to say. She explained it so well. Thank you. So HER2. So that means that is there his. So I think of it as her, like her. Two means that there's a 1 and there's a 3 and there's a 4. But like Laura says, it's the raising hand. So when I try to think about it, it's like antenna on the head of the cancer. So it happens about 20% breast cancer patients and makes the cancer grow really quickly. So I think it's an antenna. So all these antennas are sticking up and they're talking to each other and it makes the cancer grow. It can have the estrogen receptor too, but that HER2 makes the cancer grow really quickly. So Maria was one of the PIs that she's been leading some of the key trials back in the 90s where this drug called trastuzumab Herceptin just got in the way, just elbowing. So those hands don't touch. The intent just shut down, the cancer dies. That's the magic of this antibody. It's a chemo. It's an antibody, so it's special. And it just detaches and it goes in between other hands and it keeps on doing its work. And so the trial that led to its approval was in women with metastatic cancer. This was back in the 90s. And it led to really good response rates. And they started to add it to chemo. Back then we were using chemo because that's the tool that we had. Chemo is chemicals that kills cancer, just in non-targeted, just zapping the cancer. But here was this trial, and how you remember this, and Frank and all of us remember this, that this trial in over 400 patients who were courageous to be part of our clinical trial showed that adding Herceptin to chemo like Taxol, we still use it, and also Drumycin, we used it back then, led to just dramatic shrinkage of cancers and patients survived. That's a very good story. And our patients are still living, many are in remission, but Maria, I think, touched upon about the heart. There's an issue of the heart. And I can speak on that when the question comes, but we discovered that there were heart trouble with this drug. And it was really with the drug adriamycin that we were using a lot. And how you led some key trials looking at adriamycin, and it hurts the heart. It's a good cancer drug, but it hurts the heart. And so what we learned is that, well, HER2 is also found in heart. So in cancer, it makes the cancer grow quickly. So that's bad. But in heart, it's good. The heart repairs itself. So if heart is pre-injured, for example, if a person has heart attack or high blood pressure where the heart's been stressing for a long time and the muscle is really weakened, or the adriamycin drug hurts the heart and you don't know it until you know it, meaning the patient starts to have heart trouble with breathing. You give a drug like Herceptin, gets in the way, it's blocking that HER2, it needs to be on to fix the heart. And the heart can't fix itself. This is where we find that there's heart failure in our patients when they get this drug given together with adriamycin. We learned a lot. Women were surviving this HER2 positive breast cancer, but what we learned is that we cannot give this medicine with the drug adriamycin together. So I'll just leave it at that. And that was in the 90s, led to the approval of this wonderful drug in 1998.
And certainly over time, we moved away. We're smarter, we're better, we're more proactive about marrying combinations of chemotherapy as well as targeted antibodies in a safer way. So we don't wind up with undue toxicities down the line in a curative, especially in TED. But we're also beginning to move away, and I hope I'm still around to see it. I think we will be, that we're moving away from chemotherapy and these special subtypes with antibody drug conjugates, with immunotherapy. And I have a question for both Dr. Iyengar and Dr. Musk. Immunotherapy. It's become coupled with triple negative breast cancer. And I suspect down the line we're going to see it travel its way to other subtypes as clinical data matures and we have safety and we have survival data available. Neil, can you explain to the audience what immunotherapy is? You see on television, Keytruda, lung cancer. I think it's approved now in 18 different solid tumors. Can you speak to what immunotherapy is and where we're moving with it down the line? And then I have a question for Dr. Musk.
Absolutely. So immunotherapy, of course, has revolutionized cancer therapy in general and has led to increased cure rates across several cancers. I would say in breast cancer, we're still sort of at the back end of the immunotherapy push. And that's largely because of what you brought up earlier, Maria, that breast cancer is a heterogeneous type of cancer. And some breast cancers are very immunogenic, others are not. Some are more driven by estrogen signaling, others are not. But what we learned is that we can manipulate the immune microenvironment, that's the cancer interaction with the immune cells surrounding the tumor, to actually then take the brakes off, if you will, those immune cells so that they are attacking the cancer, or trying to clear the cancer, or generating a microenvironment that's more hostile towards the tumor. And this has been incredibly successful for certain types of tumors that are really driven by evading the immune system. One of the ways that our body protects us from the development and growth of cancers through immunosurveillance, which is the ability of tissue-resident immune cells to recognize when there's a foreign cell or a dysfunctional cell that's developing and essentially to clear it. But cancers have developed ways to cloak themselves, to hide from those mechanisms that our body has, those immune mechanisms. Immunotherapy removes that cloak and can allow the immune microenvironment then to do its job and to attack that cancer. Now, what we've also learned in breast cancer, and Murray mentioned triple negative breast cancer, is that immunotherapy by itself sometimes isn't enough, and we need to give tumor a push, whether that's chemotherapy or other therapies, in combination with the immune therapy, we're now studying strategies to make immune therapy more effective in breast cancer. So in triple negative, it's the combination of chemotherapy with immunotherapy. In estrogen receptor positive breast cancers, immunotherapy initially was not very exciting. It wasn't very active. But what we're learning now is that in certain types of estrogen receptor positive breast cancers, those that express low levels of the estrogen receptor and may not be entirely driven by estrogen signaling, those respond very well to immune therapy as well. There are also studies that are going on to figure out how to make a tumor more immunogenic. So can we give either vaccines or other types of novel therapies to essentially alert local immune system that, hey, this is not a normal cell. This should be cleared. So those types of studies are ongoing, and we're seeing some really interesting preliminary data. We're also learning that we can use some of the tools we've been talking about, like next generation sequencing, to understand genomics of the tumor. And some tumors carry a lot of mutations. We call these high tumor mutational burden. And when that happens, when a tumor has a lot of mutation, of course, these are not the genetic mutations that you inherit or pass down. These are spontaneous mutations in the cancer cell. That generates a lot of what we call neoantigens, which are essentially proteins that should not be there. That really helps the immune system recognize that this is not a normal cell. And we can use immune therapies to then attack those tumor mutational high burden tumors. So I think what we're seeing here is a more specific use of immune therapy for very specific types of breast cancer. And as our diagnostic technology evolves to better understand what are the immune alterations in the tumor and what is the immune cell population around the tumor, I think we'll get better and better at recognizing two things. One, when can we successfully use immunotherapy in the treatment of breast cancer? And two, what are the ideal therapeutic partners with the immune therapy to enhance its effects? Because we know that immune therapy does have side effects. There are things that it can do to our immune system in general that can be harmful to our bodies. We really have to figure out what is the right scenario to use these therapies that balance those risks with benefit.
I'm glad you wrapped it up with that last sentence because, yes, these are life-changing therapies, these targeted therapies and immunotherapies. They certainly have enacted cures where we didn't see cure before, but they're not without their side effects. And it is our burden to educate our patients, our ancillary services, our sales all the time on to pick up potential adversities when they're potentially treatable and reversible. And I guess with that, nothing comes without a side effect. Getting married doesn't come without a side effect, but we'll leave that alone. Dr. Muss and Dr. Banway, also geriatric oncology, but Dr. Muss, I take exception to the word elderly. I think we should rephrase it to the mature vital patient. But we do see patients in their 7th and 8th decade that are diagnosed with triple negative. They're diagnosed with HER2 overexpressing breast cancer. And I'm not talking about a stage 4 setting where the disease itself is very threatening, as we have to do whatever we can to reverse it. But early stage 1, 2, when do we say it's not okay to treat a mature, healthy 75-plus patient versus observation? Or please, can you just speak to that?
Yeah. So, by the way, we're changing geriatric to cancer and aging. We've gotten rid of senior, all these terrible words.
Thank you.
So the
When I
challenge,
see clinical trials and they say in the 65 plus and over, there were more side effects.
yeah,
I want to shoot the board.
babies. So cancer is a disease of aging. And it's underappreciated in the United States that about the average age of a cancer diagnosis in this country right now is 67. So a lot of the images we see, the marketing, you never see older people in ads and everything. It just doesn't happen. So the challenge of caring for older people with cancer is really trying to figure out how any treatment we give, whether it's surgery, radiation, immune therapy, chemo, is going to interact with their other problems that they may or may not have. So a lot of the things we're doing in the United States with older people, and we really should be doing it with everybody, is assessing older people, not only for the other diseases they come in with frequently, like heart disease or lung disease, but all types of things like their social situation, their nutrition, things that really affect their life expectancy. And so the way we figure it out is we do an assessment. It's very easy to do. And we try to figure out if Mrs. Jones came in with heart disease and other problems, how much that is that going to affect her life in addition to the cancer now. And if it's really serious problems that are going to affect her life expectancy exclusive of the breast cancer, we may modify treatment and omit certain toxic therapies or lower the first dose to just make sure things go well, as opposed to just jumping in with normal treatment that we would give to a healthy 50-year-old. So it's a process to figure out what the other diseases, how do they figure life expectancy, and that can all be done pretty accurately now. There's a lot of great tools we have in this country to do it. And then look at these other things. Is this woman in shape to handle modern, high, perhaps high toxicity chemotherapy? And that's kind of basically how we're doing it. We're making a lot of progress. Not everybody needs everything. When we get a new drug, it may improve survival, but it's not like if you didn't get the new drug, your survival will be terrible. It's really pretty good.
We have to be careful. The implication is that 100% of our patients with that specific diagnosis is going to recur, and that's not so.
That doesn't happen.
Treating patients that never really need a treatment.
Right. So if you had a treatment where it would improve survival to 50% of women, and you have a new drug that's 60%, okay, if you add it to the old, but that drug is very toxic, and then you have a really older person with serious other diseases. For that 10% possibly with those risk of side effects, it may not be worth it. And it requires a lot of discussion. Got to get patients' input, like what do they think about it? They need to know about the side effects, and then make a shared decision that's best for the patient, not best for the oncologist, but best for the patient.
Great. First, I just want to question here. How does AI help us be more effective from a time perspective in planning to be able to do the kinds of assessments in the mature patient that we should be doing, but do we have time to sit down and plug everything in? How can AI help us in that sense?
So I think before
about Claude today.
AI has been a game changer. I think obviously you can plug in a lot of the patient characteristics and it sets out a certain risk, right? So even before that, for example, in my clinic, and Dr. Moss in North Carolina, University of Rochester, they've done a lot of the work in geriatric oncology. For example, in my clinic, from when the patient is sitting and waiting to be called to the clinic room, I have a 3-meter walk test that I have pre-planned. And as they're walking into the room, I, elicit the help of an MA to record that time. And perhaps you can, when I was training, that one of my projects where I looked at, can I relate to peripheral neuropathy that way? So the person was walking in completely fine and on Tackle or what have you in chemotherapy. The walk is a little bit slower. I do a hand dynamometer. So, those are the things that we can do in clinic on natural, kind of setting. But AI, as you said, I think it's, for example, polypharmacy in geriatric statins, PPIs and PIs interact with a lot of the stuff that we give. So I think our calculators and AI has provided that time saving in that you can plug in all of the medications and see the interactions that for whatever you're proposing in the regimen, is that interacting or not. So I think that is somewhere we can make use of that information.
Thank you. I'm going to get to you, Frank, in just a second. Just reminded me of a story when you said you watched that 3-meter walk. When I was at Memorial Sloan Kettering, my office was situated with the corridor. So the patient would have to walk down the corridor to be escorted into the exam rooms. I had 3 exam rooms next door to my office. And I had a patient who transferred to me from NYU with, she was probably close to 80 years old, widely metastatic disease to her bony skeleton. And when she came to me, she was on narcotics. And every time she would come to see me, she would ask for a refill of her narcotics. And I remember I was sitting in my office that day. It's rare that I got to sit in the office. I was always running from room to room. And I looked up and I watched her walking very gingerly toward the exam room. She had a zip in her step and she moved fluidly. And I went into the room and I said, you're walking terrific. She said, oh, but doctor, I heard everywhere. And I said, but I just watched you walk towards me and there wasn't one frown on her face. There wasn't any grimace. And she looked at me and you said she loved me. She said, all right, I'm going to tell you the truth. And I said, what is it? She goes, I don't have any pain. And I said, what are you doing with all the pills that you get for pain? She said, look, I'm going to say it out loud. The system in this country is such that whatever I get from Medicare, I can't pay my rent, so I sell them on the corner for $30 a pill. She said, all the seniors are doing that in my neighborhood down in the East Village. And I just looked at her and I said, boy, am I in the wrong line of work? But I haven't thought of that story forever. Frank, please, you wanted to comment.
No, everything is relative, right? Back in the day when I was an oncology fellow, the disease known as Hodgkin's disease was really a killer. We were slap happy because we had this new thing called MOC. It was a combination therapy, and it really was a lot better than we had before, and people were happy, but still, 20, 30% of the patients were dying and had toxicities that you wouldn't believe. And then we had a new therapy, ABDV, of initials. And now we're up to like 97% cure. So what was disease that was a killer is now a disease that's curable. So if I had a person come to me that was in med shape, that had Hodgkin's disease, I may well be pressing on the gas pedal a lot, saying, I can cure you. Versus, I got a combination, I'm going to put you through some hurdles here, but the likelihood is, well, I may, but I probably won't. And I think breast cancer has done such an incredible job over the last 20 years, but in the last even 5 to 10 years is amazing. So part of the idea of who gets treated, why should we treat, has to do with what we can do. If you can't do anything, and what we should not do. So if you have medicines or therapies that are just really on the edge, you have to be honest. You can't give them a commercial for television. You have to say, this is what is going to happen. We have a shot, and do you want to take it? It is a conversation. It is a dialogue. And it can't be you're prescribing this only.
Tana, you knew it was going to get to you. So, all 6 of us prescribe medications, and now with new data that's come out, even in an early setting, ovarian suppressed patients with the goal of increasing survival as well as disease-free survival in patients, often not permanently, maybe for 5 years, but we do it. And in some instances, we cause ovarian suppression just with the medications that we've used in an early setting. How do you approach a patient? And I'm not going to not get to you, I promise. How do we approach a patient who comes to you saying, I'm having a really tough time with vasomotor instability, hot flashes, vaginal dryness, my libido is low, and she may be a 20-year-old or a 65-year-old with estrogen-positive disease now on endocrine therapies.
I think the approach, I mean, ideally, if we're seeing them early in the course, oftentimes, unfortunately, we're not, and sort of the effects are so severe that it prompted them to actually speak out. But I think the approach is multifactorial in the sense of we first try to figure out what are the systemic symptoms, what are the local symptoms, the hot flashes. Obviously, this could be a whole other discussion about the non-hormonal medications, and I think you'll be talking about that later. And lifestyle, absolutely. For management of the hot flashes, I think the first thing is to take a step back when patients come in like this and say that, we can treat things. There are ways that we can treat this. Hot flashes, definitely looking at lifestyle changes, non-hormonal remedies. Definitely the atrophy is really dramatic. People don't often know, or patients don't know, of all of the treatments that are out there. And so I think just coming out where they have some answers, we have an initial, treatment plan, looking at things from medication to physical therapy to mental health therapy as well. Sexual counseling and therapy is a huge component. So there's just so many things that we're going to address. It's not just looking at, doing a GYN exam and the just one specific anatomic thing. So I think hopefully we're addressing, all of these things, understanding and telling the patient that it doesn't have to be just because you have a hormone receptive, a breast cancer that, you're out of luck. There are so many things, and more talking about new treatments. I mean, yes, these are cancer-directed treatments, but now there's a lot more effective FDA-approved treatments that has been a game changer. Yeah, for sure.
Thank you. We have a question from the audience.
Yeah, we actually had two questions from the chat. Can you hear me?
Go ahead.
The first is, what are the treatment options for a HER2 low diagnosis?
Okay, I'll actually take that. Okay. HER2 low means that the arms are up in the air, but not that many of them. And it all depends on the stage. And HER2 low is something to look at in advanced stage 4 disease, to see if we can treat someone who may be refractory to their endocrine therapy or a chemotherapy that they might have been treated with. And there are some new antibody drug conjugates that are available today that have been very successful in the advanced setting. And we now know that we can use those anti-HER2 new antibody drug. An antibody drug conjugate means here's the antibody, and there are chemotherapy molecules attached to the antibody. When the antibody goes to separate those hands that are trying to hang on to one another, the tumor excretes an enzyme that melts the linker, and those chemotherapy molecules can kill the cell and neighboring cells. Okay? Did you get that? Did I confuse everybody? We'll go over it during lunch. So these drugs have been found to be very effective, even in earlier settings. A drug like Enhertu that we used at the stage 4 setting for metastatic disease that was HER2 new overexpressing now is also being used for estrogen positive HER2 lows, even some estrogen negative HER2 lows and ultra lows, and now it's coming into the earlier setting. So yes, there are treatments for HER2 low. We're looking at HER2 low right now only in the stage 4 setting. The other question?
What is the role of Signatera in testing for breast cancer recurrence? Is Signatera testing useful in the context of metastatic disease?
Sure, happy to take that. So this goes back to the conversation that we were having with regard to circulating tumor DNA, and now there are several assays that look for MRD, or minimal residual disease, which is essentially a method to test for circulating tumor DNA. And the idea is that if you've completed all of your adjuvant therapy, your chemotherapy, your hormone therapy, but perhaps there are a few lingering tumor cells that were resistant to these therapies or developed resistance to these therapies, then perhaps we can detect the presence of those cells through that tumor DNA shedding. The issue, though, is in that setting of minimal residual disease, micrometastatic disease, you can imagine you can draw 4, 5, 6, 10 vials of blood, and you might still miss very small amounts of residual disease. But fortunately, the technology is getting better and better and better. Signatera is one of the companies. There are several others to detect very small amounts of residual disease or circulating tumor DNA. You can have tests that are tumor-informed or tumor-agnostic. What that means is that we can just test for cell-free DNA, any DNA that's shed, and there are some key features that make it likely that DNA comes from a cancer cell, specific types of mutations or alterations, or you can have a tumor-informed assay or test, which is looking at the tumor that was surgically resected from the breast, looking at its molecular makeup, what are the genetic or genomic alterations in the tumor tissue, and then looking for those alterations in the DNA you find in bloodstream. And those tend to be a little more accurate because you know that that reflects the original tumor that was removed. So the technology is getting better and better. And what you'll hear now is that there are some advocates for doing routine testing every certain number of months and so forth. But the issue is we're in a spot right now. The technology has advanced or continues to advance so rapidly, but the ideal or optimal use of that technology, we haven't caught up yet. We haven't finished the trials. The trials are ongoing to figure out what we were talking about earlier, about whether or not we should be thinking about escalating therapy. Should we continue observation? Are there other things that we can do? And there are a whole range of interventions that are being tested on clinical trials right now. There are new anti-estrogen therapies, the oral SERDs, for example. We're very soon about to have a new oral SERD, giredestrant, that will be approved in the early stage setting. That clinical trial.
First time in 25 years.
First time in the 2 decades. It's remarkable. And that trial took the approach of let's just use the new drug for everyone so that we can avoid the development of resistant mutations. But there are ongoing clinical trials right now in the adjuvant setting where testing a switch strategy where you start with standard endocrine therapy like an aromatase inhibitor, and then later you switch to a novel oral SERD, so that if a resistance mutation develops, like an ESR1 mutation, you can overcome that with one of the new anti-estrogen therapies. So these tests can sometimes help detect those resistance mutations that are developing. But again, it really comes back down to when is the optimal time to do the test. And right now, we don't have that answer clearly just yet, but we're getting there.
Let's give a hand of applause to this incredible panel. What we're going to do for this next segment is talk about advocacy. And I don't want to spearhead the program. I'm actually going to turn it over. And I'm going to sit back here on this chair and eat my lunch. But I think this is really an important segment. It's the role of patient advocacy. And that is not a small voice. That's a huge voice. I will tell you that many of the treatments that we have with curative intent today in the breast cancer arena are because of the advocates and industry getting together, marrying and no divorce, and really spearheading what we can bring to the community. I'm passionate about this, a big believer in this, and everyone that is on the stage right now has their own role in bringing that mission forward. I know you're going to be surprised, but I really want to highlight Rachel Rupright. Come on, stand up, say hello. She's the NYOH Foundation Administrator, and she oversees the programs and she puts forward multiple programs. Why? Is it fundraising? Absolutely. Where do those funds go? To patients who are in need. And I will tell you that although we got a very healthy seed grant from my patient, Stacy Fisher Rosenthal, which allowed us to move forward, Rachel was really in the forefront of helping get more industry sponsorship that would really create a nest for patients in the future and more programs. She worked tirelessly over the past This whole program got put together, by the way, in 3.5 weeks. How do you like that? So, bravo, bravo. And I hope you keep your energy up, and you may have something to say about being an advocate for those patients. Next to her is sitting Emily Rubin. Emily is a writer. She's a published author and a writing instructor. And I will say that you will hear from her. You will hear about her writings. I don't know, did you bring any copies of Stalina in or anything else? No? Okay. She'll tell you all where to find it. But Emily is someone who was diagnosed with triple-negative breast cancer 10 years ago and just got diagnosed with her second triple-negative breast cancer just a year and a half ago. And I think the writings really started 10 years ago. You run the workshops at Mount Sinai and up at NYOH. And again, such a mission in her workshops to allow patients who sign up to find their voice. And we're going to hear from Emily. Well, Myra, we've already heard about. She is the money maker and never for anything that would benefit her. She has to work tirelessly and be everywhere all the time for an incredible cause, which is the BCRF, the Breast Cancer Research Foundation, who has raised over $70 million for breast cancer research. It's because of Myra's tireless efforts and all of the people she's trained to continue those efforts that we have brilliant young people and even older, mature people really thinking about research and breast cancer and innovating ways. I'm waiting for breast cancer to go away and I'm going to open up a Greek diner. I'll be out of work. That's what I want. So, Frank, you've already met, Dr. Arena. And I have him up here yet once again because Dr. Arena runs the largest advocacy program down in Long Island. His programs can sometimes have 1,000 attendees, and he grants also research monies to conquer cancer, as well as the research foundation under his name. And again, it's a second full-time job besides just taking care of patients. Well, then we have someone who was surprised when I invited her to come here. Diane Granger is Patient Financial Services for NYOH. Why is Diane here? Because I can't tell you how often, at least once every other month, I handhold a young patient who needs treatment but was told that her copay would be $3,000 every month. I handhold an older couple, and I'll give you an example. I have a woman who's in her 70s with metastatic breast cancer who transferred to my care just under 2 years ago. Her husband was diagnosed with metastatic prostate cancer. And I walked into the room one day. I was about to change her treatment. She had progressed, but I was very optimistic. We had a new treatment that I was hoping was going to be just perfect. And her husband looked very solemn. And I turned to him and I said, "How are you doing? How are your treatment?" And he said, "No." I said, "What does that mean? No." He said, "My wife," and he pointed to her, and I sat down at the dining room table. "We can't afford the co-pays for both of us, so we decided only she will be treated." That should not be happening in a world where we know how to read and write and support one another. Diane makes it happen. Diane is the one who will do everything she can for that $3,000 copay to disappear for the husband now being treated for his metastatic prostate cancer. So I can't think of a better advocate. She'll tell you more about herself when the program starts. And then we have somebody that is way too near and dear to my heart. I wonder sometimes, should I keep our friendship or should I fire her as a patient? Um, she is beautiful on the outside. She's beautiful on the inside. Lauren and I met each other over 2.5 decades ago at Memorial Sloan Kettering Cancer Center. She had just delivered a baby and she was diagnosed with an unfortunate aggressive breast cancer. All right. Remember, I said over 25 years ago. All right. So I want smiles in here. She had been treated for Hodgkin's lymphoma when she was about 19, 17. And part of her treatment was anti-radiation, which put her at a high risk of developing other malignancies, namely breast cancer, subsequently diagnosed also with a thymic cancer, and is an advocate, makes herself available to everyone in the Hodgkin's arena as well as the breast arena. She's this wisp of a woman, is one of the most ardent and aggressive trial attorneys. Okay. And I think it's only because she surprises the opposite attorney because they think they're going to wipe the floor with her. And she usually wins. And always for women who are unserved or abused or being taken advantage of. So, someone that you're going to want to hear from. The last person that I'm going to introduce, I really don't need to read this, but I'll do the right thing and behave myself. Mary Jimenez is just a barrel full of energy, spit and fire, and has been part of industry when I met her over 2 decades ago. And it was interesting. She just wasn't on the sales force or managerial force, but really was passionate about the patients she would come across and listen to their stories and take their stories to heart and developed a sense of advocacy supporting them. And now, after all these years, she is the Alamo Advocate Program Director. Alamo Advocacy Program in San Antonio is the largest advocacy program, patients supporting patients, industry supporting patients in the country. And I will tell you that she will run next session. I said I'm going to sit back there and eat my lunch, but she is someone that deserves all the respect in the world, every honor in the world, is a role model for her children, her friends, and everyone who adores her. And thank you for doing this coming from San Antonio. Mary, this is all yours. I'm going to go eat.
All right. So first of all, thank you all for inviting me, Dr. Theodoulou, trusting me in sharing just what the role of advocacy does here. And you'll see from these amazing advocates that you could be a caregiver and an advocate. You could be not a patient necessarily and be an advocate. Doctors are advocates, right? And so you'll hear from some survivors here today, their role of advocacy and how their career has transformed their passion to helping you walk forward tomorrow. And hopefully, as Maria said, with some tool that inspires you to be empowered? Because you heard earlier today, education is everything, right? We grow up, our parents tell us what? You got to read and write. You got to go to school. I told my kids they had 16 years of school and they looked at cross-eyed because I said, I got 4 years of college. It was non-negotiable. You can't take away your education. You can take away other things, and that'll help you with your journey. So I hope today is really exciting. These are amazing ladies. As Maria said, the Alamo Advocate Program that is my seat spot. As I see, it's taking everything I learned from my mother, who is my role model, and empowering education. And it is really amazing to see the role of advocacy. It started with the AIDS pandemic, and it was really through them that breast cancer propelled. And now today, there's many other disease states that have advocacy. Stomach, there's lung, gastric organizations out there. Just about everyone has jumped on board because they've realized they have to have a voice, and they've got to help the doctors together in partnership, along with industry, as you'll hear later today, just what their role is as well. I want to start with Diane. As we mentioned earlier, Diane is a financial counselor. And Diane, I wanted to ask you, can you describe your experience working with diverse populations, which often have different needs?
Sure, thank you. Can you hear me? I tend to be very loud, so I won't hold the microphone too close to my mouth. But certainly at NYOH, we have very diverse populations. As you already are aware, we can have senior citizens, we can have young people, males, females, many populations. Some with insurance, some without insurance, some who simply just didn't realize that they had wrong insurance. Some who come in with, 2 people in the household making upwards of $150,000 a year who have no problem meeting co-pays or deductibles and things of that nature. And others, like Dr. Theodoulou said, who come in and just say, we can't both afford to be sick, so we're going to take turns, get medicines and things like that. Anybody in this room a state worker? Show of hands, like anybody a state worker. Do the Empire Plan. Wonderful. You do not need me, and we will probably never talk. It is the best plan in New York State, and it's going to pay everything for you. Don't ever get rid of it. Okay. It's wonderful. But then there's other plans that, the rising cost of healthcare is brutal for our employers. We always want to say, oh, my health plan sucks. How many of you have ever said that? It's not always. Yeah, even those of us that work in healthcare, my plan sucks. I know that. It's not always the employer's fault. The cost to them is astronomical, and a lot of that is since COVID. The costs were just ridiculous. What went out the door in claims. So they're forced with rising costs. And what are they doing? They have to, of course, go back onto the patient and the employee. So no one can afford the cost of that. So that being said, of course, anyone with cancer or facing these cancer copays, it's ridiculous. I had a patient yesterday who 5:00 last night, I got a call, $5,000, one treatment. You heard about Kitchener earlier? It's an amazing, amazing drug. I think one of the doctors shared with me today, 40 indications now. That's wonderful. Have you seen the commercial on TV? Who do you think's paying that commercial? You are. Yeah. That is the most expensive drug on the market. How many of you have Medicare? A standard Medicare Advantage plan or original Medicare Part B? 20% coinsurance. What's a 20% coinsurance on a most expensive immunotherapy drug? A lot. One treatment, you're going to max out your out of pocket. So what are you going to get? Phone call from our accounts receivable department. You owe us $5,600. Who can afford that? Even if you do make a lot, Do you want to pay $5,600 a shot of Keytruda? I don't. I'd rather go on vacation. I'd rather spend it on my grandchildren. I want to keep your money in your pocket, right? Anybody here with a high deductible plan, commercial? Yeah, you're going to pay the whole thing. Forget the 20%. You're paying the whole thing, right? Yeah, no, we don't want to do that. Okay, we do not want to do that. So for anybody with a commercial plan, we can get you a copay card. Because guess what? We're going to pay the whole thing for you. They're going to pay the whole thing. Anybody with Medicare, we might be able to apply for patient assistance program. They exist. They might give it to you for free. Because guess what? Merck, yeah, they have to pay taxes on all that money they're making. So they might be willing to give it back to you for free. Okay? So these are the little avenues and the little tricks that we have that we can make this work for you. Okay? Is your Medicare Advantage plan the best plan for you? They advertise all this stuff for free. May not be the way to go though, because there's a supplement plan. Anybody in here have a supplement plan to their original? Yeah, it's pretty good, right? Pretty good. Maybe a deductible, maybe that $283 Medicare Part B deductible, but then, hey, guess what? Everything after that's free. Covered, right? We can sit down and talk about that. That might be a better way to go. Okay? There's a lot of different things. What you don't know, you don't know. You don't know that you don't know these things. Anybody in here ever have Medicaid? And don't be ashamed of that. It's not a bad thing, right? Not a bad thing. There is managed long-term care Medicaid for our senior citizens. Doesn't mean low income. Because guess what? New York State does not want you in their nursing homes. They don't want to pay for that. So if you're over 65 or if you're disabled and collecting Social Security disability, they want you to have managed long-term care Medicaid. So they're going to up that income threshold. They're going to let you own your house. If it's more than $1 million in value, well, they might say no. But anybody in here have a house more than $1 million? Okay. They're going to let you have a car. They're also going to give you an aid that they're going to pay for. So there are great resources out there. You just need to be educated on that. Every one of our NYOH locations has a patient financial counselor like myself at your disposal. We never want to hear, I can't afford my medicine. We never want to hear, I'm afraid of my bills. I can't pay this. We are here to help you. We are absolutely here to help you. Okay? There are many programs and services out there. Our NYOH Foundation, Rachel gets money in, we take it away from her. We give it back to you. We're your connection for that. Call us, you tell us what you need, we're going to make it happen. And Rachel likes me. So that's what we do for you, okay? Because financial fear is really a clinical issue. How can you focus on your healing if you're afraid of the bills and afraid of the costs? Okay? Whatever for that.
Yes, thank you. Thank you. I think we've got an amazing writer among us here today. Emily, your career, a successful career as a writer, can you share a little bit about how that's transformed you into helping others with breast cancer?
Sure. I like to say, rather than a writer, that I write. Because writer is a very highly elevated position in the world. And I've had my own mentors in that, and I am extremely passionate about that practice and in my life. And after while I was going through treatment in 2008 for breast cancer, I put my writing practice to the side because I was dealing with having not great insurance and getting bills that were very scary. And and also dealing with treatment and the shock of all that. But when I was done, what I had in a drawer was a manuscript for a novel that I had been working on for several years. And I was like, oh, I'm done with cancer. I'm going to pull those 300 pages out of the drawer and look at it again and see what it is. And I did that. And it's a story about a Russian immigrant. And it was based on a class I taught in Bright Beach, Brooklyn. And they were all older Russian immigrants who came after the fall of the Soviet Union. So my background is from Eastern Europe, generations ago. But I relate to those people that had stayed in Russia and lived. They were all kids during the Second World War. So the story just had that essence to it. I pulled that out of the drawer. I sent it into a few places, agents, publishers, rejected. And then it won a contest. And the contest prize was a publishing contract with one of the top 5 publishers. And so it was, to me, like winning the lottery when you're a writer. And I felt like I had my right life back. And then while I was going through all those stages that you go through when you're publishing a book, I felt something in my breast that had been operated on already. I felt something again. And I thought, the fear, the PTSD, all of that experience came back again. It ended up being nothing that I needed to worry about. But I realized that cancer was a part of me and that I wanted to address that fear and that vulnerability and that strength that I had from going through it by going back to the hospital where I was treated, Mount Sinai. At the time it was Beth Israel, but now it's Mount Sinai, and to offer a writing workshop. And that was 15 years ago. And they said, yes, we don't have any money, but we can give you a room. And they put up flyers and 12 people came. It's free, always free, still is free today. And I've been doing the workshops ever since. They've moved to Zoom. When I moved up to the Hudson Valley full time during the pandemic and left my Manhattan life behind, I came to Francis Ford and Rachel to offer the workshops for NYOH. And those workshops started 4 years ago. And so what happens in the workshops? How do I get people going? I offer writing prompts. I say, write about the worst meal you ever had. Write about how you were named. Where did your name come from? Your first name. Let's go there first. And so people in the workshops, we get to know each other through our writing. I also elevate it to goes beyond we're not writing Dick and Jane stories, although you're welcome to write one of them. But I go, let's look at Virginia Woolf. How did she write about illness and fear? And so I say to people in my workshops, you've been through cancer or you're a caregiver helping somebody through cancer. What do you have? You have fear. You have vulnerability. You put your boxing gloves on to fight what you're going through. You have to make incredibly difficult choices, but you make them. You address mortality. And all of those things make for really great writing. So all of that has elevated people, the community that develops around that. It's sort of, to me, kind of magical what happens in the workshops because the writing pours out of people. It was so literary. It wasn't just therapeutic. It was literary that we published 2 anthologies, which I think some of you picked up, because the writing is at a level that should be published and should be read. And so I'm just going to say something because I had this long journey of breast cancer this past year. I was at 18 months. I was going through treatment and I kept the workshops going. Why? Because that was my community. of a sudden that all the people in the workshops, although there was some kind of shock, it's, oh, our teachers going through this. What does that mean for them? But boy, did everybody come around, and also my writing community support through them. So the art in the community, I want to mention one other person because she's here in the audience who became a friend who is a painter who lives right here in Hudson. Pauline DeCarlo. Pauline, just stand up. She's was a teacher at City College and at CUNY of painting. And I had seen an exhibit of hers where she had been given a solo show, but after going through breast cancer, the lymphedema in her dominant arm kept her from being able to paint with that arm. But her gallerist said, we still want you to do a show. And she did an entire series of paintings with her non-dominant arm. And one of them is of a torso with a mastectomy scar, arms raised with boxing gloves, a crown, and the word champion across the chest. And I saw that before I was diagnosed for the second time. And then when I realized I wanted to have that painting in my life. And I went to the gallerist and said, no, we haven't sold that painting. And I said, this is what's going on with me. And they said, go to Pauline, deal with the getting the painting from her. We don't want to take any kind of money from it. It's all between you and the artist. And so through that, Pauline and I become friends and collaborators. So what I'm saying about that is that the creative impulse is in everybody. And that whether it's through painting or writing or dance or music, becomes not just therapeutic, but cathartic and also builds communities. And so that's what I hope will continue to happen.
Thank you, Emily. I mean, she certainly is very humble, but she's been very well published. And there are several academic centers out there that are asking for her workshop now. So hats off to you for your amazing contribution, sharing what I call, in my household, we call it superpowers. So you are really amazing. Myra, we heard earlier about your career as always being this amazing fundraiser and academic, and then transitioning it into a foundation which has raised record-breaking funds to advance research. Can you share a little bit or share a story that's most inspired you from the research that you've raised? Obviously, we have two amazing physicians here, one joining us on stage. I think Dr. Arena isn't familiar with your work that you've done, but we have Mus and we have Neil Igar that have been recipients of, and I apologize if there's anyone else in this room that has been recipients of Myra's fundraising efforts. That share with us just what, you probably have a zillion, but
I've been blessed in my life, and I would say the greatest thing I've ever done has been to build and lead the Breast Cancer Research Foundation. We have been the largest engine behind incredible progress since the year 2000. When I started, everybody got the same treatment, everybody got the same prescription, got on the conveyor belt. And at the end of the conveyor belt, some people were better and some people weren't. And we began to wonder why. I was vice dean at NYU Medical Center. Ellen Lauder, the S.G. Lauder Company, was my dear friend, also a survivor. And she called me one day and said, I've gone on the board of Memorial Sloan Kettering. I see how rapidly research is advancing, and there's no single entity supporting that research and accelerating it, and I need you to start a foundation. And I said, Evelyn, I've just become vice dean, but it was very Talmudic, and she said, because I can do it, if I don't do it, it would be a sin. How do you say no to that? So I got the foundation off the ground. I spent a couple more years at NYU, and then we really hit the ground running. And we are today the largest global funder of breast cancer research. Now, we just announced grants of $75 million to 260 researchers across 17 countries. 30% of our investment is in metastatic disease. I couldn't have said that 20 years ago. But today, we use the phrase when you and I spoke, people are outliving their disease. And that's thrilling. The progress has been undeniable. We are putting money in the hands of researchers on the front lines. The discoveries that BCRF fueled along the way are amazing, whether it's Mary Claire King describing the BRCA1 gene, then the BRCA2 gene, Myomaprint, Oncotype DX, AI in advancing screening with mammograms. Every step of the way, lives are saved and people are thriving. We now know that less is more, as you heard from some of the experts. And it's thrilling to support HIMAS, to support Neil Iyengar, a legion of champions on the front lines, and makes you want to cry. These are not people who are getting rich. These are not people in pharma. These are academics. That's all we do is put money in the hands of researchers in the labs and researchers at the bedside, and it's making an enormous difference in women's futures. We invest in everything from prevention to diagnosis to treatment to survivorship, which is a word we never used even 10 years ago, and to metastasis. So I am honored beyond measure to have been the leader that's produced funds to go in hands of researchers who have an idea. The other thing is, having been begging for money for a lot of my career, now that I give away, I know how to do it well. So if a researcher would come to us and say, you know what, the proposal I gave you isn't bearing fruit, but if I take a left turn, I have an idea, we say, do it. Keep the money, do it. Very few funders are as flexible and as engaged with their grant recipients as BCRF. You asked me what I'm proudest of that when we were on the phone. A new grant called Atlas, and it's focusing on trying to understand why some people who have every risk factor don't get cancer. What is it about them? We're looking at twin pairs. Why does one person get it and the other twin not get it? Why does somebody exposed to high-risk environmental carcinogenic environments not get it? Why does someone with high family risk not get it? So this Atlas study will be very revelatory. We just put $1.5 million into it to see if we can understand and parse what the antibodies, what the immune system, what are the factors that differentiate. And we're looking at centenarians to understand how they got there and they're still healthy. So every day I'm gratified by what I've done and what the money has yielded. It was the greatest honor of my life when Evelyn suggested I take this on. And I said to her, we'll build an engine, we'll do it, we'll take it internationally. They were funding, she had an idea, well, I know a lot of people in New York. I said, there's a lot of great science outside of New York and around the world. So we built it. We built a first-class organization. We have no endowment. So we give $1 grant a year and then we renew. And why don't we have an endowment? Because we believed that we will go out of business. And that's pretty thrilling. The other thing is that increasingly we are further along with breast cancer than many other cancers because of BCRF, but we're also finding commonalities in cancers. Many cancers have more in common with other forms of cancer than with each other. So I'm just one lucky duck who had an opportunity, and The public and companies have responded warmly, and we're hard at it. We're going to cure this thing. Thank you.
Thank you, Myra. We're very fortunate that the Lauders believed in you and brought you forward. Because of this, you've really helped raise a lot of awareness to research. And I'll tell you, the conversation we had earlier this week was, many of you all know that the NCI and NIH funding, you see it on the news. Pick up a paper where funding was just getting cut, right? It's just fortunate, and funding in research and important research, as she's described. And have we not have organizations like the Breast Cancer Research Foundation, we would lose years of work. So I thank you again, and I think everybody in this room is really appreciative of your commitment to research and funding.
Between COVID interrupting clinical trials and then the diminution in federal funds, a lot is at stake. We are not dependent on federal funds, but there's a long line at our door from organizations that had been the recipient of federal funding. So the demand is tremendous, and donors have been very responsive. With COVID, we were concerned people weren't going to get their tests. They weren't participating in clinical trials. When you interrupt studies, you don't just pick it up where you were. You've lost critical data, and you have to go back to the beginning. So this is a very important time for the engine that is BCRF to continue its work. I thank all of you.
Wonderful. Thank you. Next, we want to hear from Lauren. Lauren, our amazing attorney from New York, the New York area, how she has transformed her advocacy early on with her own breast cancer and lymphoma cancer that she had early on at the age of 17. She learned quickly how you had to be advocate, and that transformed her skills into being an attorney. And I think that's why she's so amazing at the work she does, is she advocates for, as you heard Maria earlier, with women in family law, helping them be that voice and encouraging them to be advocates for themselves and their families. So, Lauren, I'd love for you to just share a little bit about how you become a better advocate for clients and patients and yourself.
Thank you. Hear me? This is going to be hard for me to do sitting down because as a lawyer, I do everything standing up. So I'm going to try to talk to everybody. But first of all, Maria, please don't fire me. That's number one. Being a cancer survivor for really all my adult life, part of my childhood, has really shaped me. Shaped me as a person, as a woman, as a partner, as a mother, and as an attorney. And the fact that I am such a long-term survivor, thankfully, and those experiences really do formulate how I approach the world and how I approach my career, my profession. And really, what it really did was it fostered a passion for what I do, why I do it, and who I do it for. Most importantly, though, and when I was thinking about addressing all of you, was that I want all of you to know how much power and strength you have. And the fact that you sit here and you come to listen and to learn and to absorb and to question is really a marvelous strength. And you should never lose that strength because it's also your voice. And we all have a voice. And you don't need to go to law school or in college to use your voice. So, my advocacy skills started when I was a little girl. I was 6 years old and my parents got divorced, and I really had no guidance growing up. And I started to learn how to master my own little world. And then, when I was a teenager, I was diagnosed with Hodgkin's lymphoma. And then my advocacy skills really came into play because when you're faced with what is a life-threatening illness. I'm going to stand. Is that okay? Oh, I'm sorry. A little bit. At a young age, you don't think about dying. You think about tomorrow. So when I finished my cold radiation treatment, I decided I needed to continue my education, but I couldn't because of the effects of that treatment. So I was living in an apartment in Queens with my mother, and I took the E train down to West 4th Street, and I went to NYU. And I went into the Dean of Undergraduate Admissions without an appointment. And I said, I'd like to speak to her. And they said, why? And I said, well, she'll find out. I want to speak to her. And I waited, and she told me. And I said, I just finished cancer treatment. I'm fine. I need to go to school. I need to be like other kids my age. And you know what? She said, you're on. You're in the fall semester. So I took the E train down to NYU until I decided I needed to bury myself in some snow. So I applied to the University of Rochester. I decided burying yourself in snow with nothing to do but learn is great. It's great. Great idea. Perfect plan. I met this really cute guy. He ended up being the boy of my dreams, the man of my dreams. But I didn't meet him again until after 2 more cancer diagnoses. And I went on to law school deciding, well, I'm going to defend the Constitution. I'm going to use my voice for good. I'm going to defend not criminals, people accused, have done it in a while, people accused of crime work for the Legal Aid Society. And I did that too. And I never looked back. I really didn't. I felt like cancer had been something that taught me an amazing life lesson. And it gave me a gift. It gave me a gift of feeling invincible. But I wasn't invincible. And life went on. And I married a guy, not the dreamy one from Rochester. And I had a baby. And I was nursing her, and she was 2 months old. I felt a lump in my breast. I was, okay. So I went to the doctor, and they thought it was a lactating adenoma. But I went through all of tests, and it wasn't. It was breast cancer. And no, I have to tell you, I had one moment, and I'll tell you when that moment was, and I bet all of you have had such a moment. I was sitting in the surgeon's office who had done the lumpectomy with my 2-month-old, 2.5-month-old little girl on my lap, and she gave me the news. And I remember that feeling of falling through shattered glass when you learn that you can have this devastating thing, cancer, growing in your body. And at that moment, I felt really vulnerable. And then I looked at that little baby and I said to myself, okay, we're getting on the road again. And I did. And I did my research and I got away from this very callous breast surgeon who I met. And I went to all the major institutions in New York City and interviewed breast surgeons. I used my skills. I asked lots of questions. And I asked more questions. And I found my way to Memorial Sloan Kettering. And I had a marvelous breast surgeon and a marvelous reconstructive surgeon who then sent me to the most marvelous oncologist, Maria Theodoulou, who saved my life. And I went on, and I was a lawyer. I couldn't work at that point for a few years, actually. But I went back to lawyering and I went back to public service. And I decided in the middle of all of that, when my daughter was 8, to go back to school and get a master's in family law. Because after everything I'd been through, and now I was a single mom raising a little girl in a walk-up apartment. And I said, families need a different kind of support when they're going through trauma of their own, whether it be divorce, custody, adoptions, losing your child, getting your child back, whatever it is. They need a special type of advocate. And I'll tell you candidly, most lawyers I know are not that advocate. But I treated my new life in this realm as if my life and their lives depended on it. And when I graduated with that LLM in 2010, that lovely man from Surrey, Rochester found me, and he became part of my life again. And I have to tell you that, well, of course, I left the malignant myeloma, but that happened when he came back into life, and I had a tumor in the middle of my chest. But through it all, I must say, there's this inner strength that all of you have, all of we all have it. And it doesn't have to be about cancer. It could be about anything in your life. But there's an inner strength. And for me, my inner rod is that there's nothing that is going to bend to beat me or break me. Nothing, not even cancer. And I think the most important part about advocacy in your life is using your voice. And never, ever forget your voice. And ask questions and look at the people around you and know, no matter where you are, if you're lonely or you feel alone, there are people there, organizations that will lift you up and pick you up when you fall down, if you fall down. And I must say that being that kind of self-advocate is the best medicine. It's the best thing you can do for yourselves. And never forget, you own this. You have the power and you have the voice.
Wow, thank you. We're going to hear from Dr. Rena next, who's obviously an amazing friend and prominent physician in Long Island, who I think spends hours and hours seeing patients way beyond the clock of 5. As Maria mentioned earlier, taking calls, at 2 a.m. I think he still does that, but he just doesn't advertise that. Just because he has such a big heart that I don't know how he finds time, him and Casey, who's in the audience today, to be able to create this Arena Foundation. I want to hear a little bit, Dr. Arena, about what drives you with the other maybe 4 or 5 hours that you are not sleeping to be able to do things like this to help our community.
Well, Mary, thank you so much. And first of all, my God, am I impressed by these ladies. This is, I'm glad I'm the only guy here because I know I feel inadequate. I totally feel like, how did I get to sit here? I got good socks.
You got a memo.
Of socks, but Maria, this, like she said, we got it covered. Most of the things that I think all of us we learn from our mom. And this is no different. So I'll tell you a story. What I think ultimately started me on this sort of odyssey of going to school, going to medical school and internship, residency, chief, all that stuff. But it started with mom. So I lived in Brooklyn. I told Hi Much this story many years ago, but I lived in Brooklyn before it was cool, in Williamsburg, way before it was cool. Over the office of my uncle Jim. He went to Georgetown Medical School, and he was the doctor for not just the block, but for the community. He knew everybody's name. He knew their dog's name. That's a real doctor. Let's face it. Okay. And I would be sitting on the stoop. We all sit in stoops in Brooklyn, And there was a little girl next door. And her name was Christina, beautiful little girl. And I would watch Christina come almost once a week to my uncle's office, come right around. And each week, to me, she looked paler and paler, weaker and weaker. And one day, my mom says to me, Frank, come with me. We have to go to see the neighbors. Okay, Mom, come with you. And door to door, we went. And my mom was talking, and after a second, third, what do we went to? I said, Mom, what's going on here? She says, Christina died of leukemia. What? Leukemia? How can my uncle do this? How can he make her die? I was crazed. I was out of my mind. My mom, being my mom, turned to me and said, Frank, if you don't like it, do something about it. Well, I did. The first paper I wrote high after being chief resident at Sloan Kettering and did my fellowship was on the cure for childhood leukemia. And I pissed off. Because, that was really big for people that are now, older than 21 who has childhood leukemia and know just how cruel it was. And now know that this is a disease that can be cured. What about the other cancers? I don't want anybody to go walk with their mom or their father or their aunt to go ask for money to bury a child or anybody. So now you know. It came from my mom. I had to do something about it. You're here today. You're doing something about it. All these people here, they're doing something about it. Each of us, no matter how small, how big, how whatever. You just got to do what you can do. You make that difference. This is not about some abstract something in the universe. This is about us, guys. This is about us. This is about legacy that we leave for everyone. I'm proud of the fact I started a foundation. We started it in 1984. I started with Martin and Barb Sass. And I asked them, I said, I have this idea. Would you help me? I remember meeting them. There's a fancy-dancy shopping center called the Americana in Manhattan, very famous. Billy Joel even referenced it in one of his songs. And I met him there. I sat on a little bench. I said, I really want to do this. At that time, 1984, it was a bad time for research, a bad time in the country. The economics was pretty crummy. Not as crummy as now, but it was crummy. And I said, could you help? Let's do something. We're going to give grants out. We're going to make certain that research continues. But most importantly, we can't forget the patients. They're sitting in limbo. They don't know what the hell to believe. And they got to believe, got to know that people out there really give a hoot. This lady's fighting for people so they get a copay. I don't have to listen to some pig-headed football player getting $103 million for throwing a ball down the street. I could care less. So we did, and we did pretty damn good. So if you see my car on the street, it has a license plate. It says Cure One. We were able to cure one already. Zalon, I don't know if you remember him. Zalon was a dear friend. In the middle of the night, he calls me up and says, Frank, I'm in La Jolla. I just heard this lecture at Sirp's clinic of a drug that fell. It was going to be used for rheumatoid arthritis. And it didn't work. But there was a patient that had this disease called hairy cell leukemia. And in that patient, leukemia went away. I said, what's the guy's name? He says, Larry Perot. Get Larry. I said, give me his telephone number. I'll call him. He says, it's a little late. I said, you just woke me up at 2 o'clock in the morning. I'm waking him up. And within a week, he was going to give rounds at North Shore University. Bob, I call it North Shore then, right? He was the chief resident. He was my intern when I was chief resident. He was a great intern. And at Sloan Kettering, I called all the people I knew. This guy's got to tell us that what about this drug? And Marty was able to, what he does well, raise money. He could raise money. And that drug became known as clodarabine. One shot, uno, cures that cancer. There. That's why my license plate says Cure One. You know why? Because I need another car that says Cure Two. And that's what I'm going to get. Because that's what we're about. You start small and you keep on pushing. Just like Lawrence said, you don't give no for an answer. There's no such thing as no. There's too many people depending on us, all of us. We're not alone. If we stick together, there's no mountain we can't move. There's no disease we can't cure. When I was a little boy, there was a thing called polio. And then we all got lined up in school to take that little tube. There's no more polio unless some moron wants to bring it back. I didn't say who. That's okay.
Thank you so much, Dr. Arena. At this point, we appreciate a round of applause for the panelists. All right. Thank you.
Okay, so we're going to go to part B of this program. Thank you so much. All of you were incredible. Just incredible. I'm sorry we're not recording this so we can listen to it later on. We're going to move forward with part B, and we're going to have some of the industry leaders come up to the stage right now. And Mary, you're going to introduce everyone and have the discussion. Okay.
Okay, ladies and gentlemen, we're going to try to get caught up a little bit here. We're running a few minutes behind, but as you heard the voice of a patient, and you know that there's unity, as Dr. Arena said, the way we're going to do this together is with the patient, with industry sponsors, and with physicians and researchers. That is the way we're going to be able to cure cancer. We need it as a community, and no one better than Maria to bring a group of individuals like this today for this setting to be able to share these voices. So I'm going to just quickly introduce our speakers, and they're going to actually do a much better job in sharing what they do in their role in industry. So these are, we're getting from two key opinion leaders that work in industry on the pharmaceutical side, the biotech side, and then we're going to hear from
a diagnostic company that has a test in CTDA. So it'll be interesting. You please feel free to come to the podium and ask your questions. We're going to keep this very fluid, and I'm going to jump right in and introduce. We got Julie Filatella. She leads the efforts in breast cancer for diagnostic test, and she's going to speak about the company Natera and what the role is in partnerships with patient advocacy and the importance of these tests. And as you saw today, there's a lot of unanswered questions and things that still need to be done, but she leads those discussions with the physicians like Neil Igar and Chaim Musk, Dr. Frank Arena, Dr. Theodoulou, to be able to pair and get those discussions moving along the pendulum so we can get tests like this in your hands to be able to navigate your care. I call it the roadmap. So then we have Deb Wafer, who is with Gilead. She is a community engagement advocacy leader with Gilead. And I told her she's a dual. She also is a clinician by background. She's a nurse by training. And I told her, once you're a nurse, you'll never stop being a nurse. And she is a cancer survivor, breast cancer survivor. So we get double dibs with her. So we can ask her questions about advocacy from a personal side of breast cancer and how she's navigated, but you can also ask questions around Gilead's role and how they reach patients and how do they reach research and integrate patients into research, right? Many of you may not be aware, but patients actually now, fast forward, we've talked about the advancement. Patients in any one of these organizations are involved in the clinical trials. They have a seat at the table. So they give input because it's so important. As they talked earlier about safety profiles and side effects. They're able, you all know, no one better can share, a patient advocate can share their experience or their feedback. And sometimes it's that trade-off. And you may pick a lower dose so that you can finish your treatment instead of being really sick just to get through that treatment, right? There are ways around this. And I think we've heard that today. So Julie, did you share a little bit about CTDA and kind of go into the vision? Because I think that's a hot topic right now.
Sure. I'm Julie Fatala. I'm the National Director for Breast Oncology for Natera. We make one of the ctDNA assays for minimal residual disease, or MRD, that was discussed earlier today, called Signatera. But what I'm here really to talk about today is really how Signatera or MRD assays like it are used today for patients, what resources are available through our company and potentially other companies, and a little bit about data behind those. Doctors Arena and Iyengar and Banwait and Theodoulou all really illustrated this morning how where we are with MRD, it has promise. I mean, you hear this phrase, if there were only blood tests, and we're, like Dr. Arena said, we might be right there. Natera has invested quite a bit, probably more than any other company. We were the first assay on the market. We've also invested the most in research behind these to really help understand, can we detect a recurrence and act on that and change the outcomes for patients? That hasn't been established yet. And that's the $64,000 question. Today, these tests are available and they're on the market and they're useful as an additional tool. The results of the test can't be used on their own to make decisions. They have to be used in conjunction with all of the other standard ways physicians make decisions. But patients do find this test useful to them, and in some cases, and physicians find it useful in some cases. And we're still learning about how that works. In the meantime, we have data that shows, the value of a negative result on this test patients is very high, and the value of a positive result can be high but it also can be challenging because Dr. Van Waite talked about, he had a patient that turned positive and he can't act on that positive result by itself. So he had a space of time between the time that result developed and potential recurrence. And physicians worry, they have an obligation not to create that anxiety for a patient. So there's a huge upside. The negative test result can relieve anxiety, and the positive test result can be useful in some cases in detecting recurrence early, but it also has that capability. So the important thing is if there's an interest in this test, that it's a decision you make with your physician, knowing all of the potential benefits and all of the potential ways it can be challenging, and then determine whether that's right for you. The test can do a couple things in addition to detecting a recurrence. It can help for patients on therapy. It can help monitor the patient response to therapy. So we know that the levels of circulating tumor DNA going up or down correlates with response to treatment. The other thing it can do, if ordered or tested at certain time points in your journey, if it's ordered before treatment, we have some data that shows it can help understand your individual prognosis. And if it's ordered during treatment at certain time points, those time points can be meaningful to help determine what your longer term outcomes would be. There are other types of ctDNA tests. We will have one eventually, but that Dr. Iyengar referred to that can help understand changes in your cancer. So ctDNA can be, the test can be used in a lot of ways. Some of the things we offer patients are, we hear today many times about financial toxicity or cost. We at our company, and most companies in this space, have very good financial policies for patients. We try very hard to minimize the out-of-pocket, or if a patient's insurance doesn't pay for it, work with the patient. In most cases, you get no bill if your insurance doesn't cover it from Natera. If you have an out-of-pocket or a copay, that is, we work with you to minimize that. We have a very generous program for that. So we really try to make access available to everybody. And, I think what's really important to understand is that it's just an additional tool at this point. The other last thing I will say is we are just launched several clinical trials, one of which has 50 sites in the U.S., which will enable patients with hormone receptor positive cancer who qualify for a CDK4/6 inhibitor to enter the trial and delay or hold on initiation of that CDK4/6 inhibitor until they turn positive. And that the purpose of that study is to help us answer that question. If we treat on that molecular test result, as opposed to waiting for a tumor to be visible on a scan, will that change an outcome for a patient? So we're working on those, but those, that's another option potentially for patient, is to enter a clinical trial that's using ctDNA is part of the trial. So anyway. Wonderful. Thank you so much. All righty. Next, just love to hear a little bit more about the work you're doing in patient advocacy at Gilead, and how you approach patients, and your work, how you transitioned your work from being a nurse into patient advocacy. Okay, is this on? Yeah.
Well, thank you for having me, and good afternoon, everyone. I came from California here.
and it was a trek.
And literally just got off the train.
Yeah, it was a trek. I had a Lucille Ball moment this morning. I didn't buy my Amtrak ticket ahead of time, and then when I got to the station, the train was full. So anyway, I felt like Lucy this morning. But thank you for having me. It's a privilege to be here with everyone. I know there are patients, there are families, and there are support systems in the audience, and that is something that Gilead engages in all the time. I lead our community advocacy and engagement team, and what we do is we are the voice of the community and the patients at Gilead. So we want to make sure that the patient's voice is always in the room when we're having discussions about our medication, about our access, about our programs. My team's job is to make sure we bring that voice and make sure that that voice is in the table. I know how many of you know about Gilead Sciences. About Gilead Sciences, but we are a biotech company that's located in the San Francisco Bay Area. And we were founded during the HIV/AIDS epidemic. And as you know, advocacy was a big thing during HIV in the treatment, getting research done. And we really just stand on that. Were founded and we always engage patients and community when we're making our decisions about our treatment. And now we've expanded into oncology. And now that we're in oncology, we're bringing the lessons that we learned from HIV into the room. And we just did some trials, and what we want to do is make sure patients are always at the table. Someone talked about that earlier, but we want to make sure patients are at the table, not just to recruit for the clinical trials, but to answer any questions that patients might have about clinical trials. We have the questions that we want to answer through science, but while we're doing the studies, let's take a look at what patients want to know too. Things like for women might be about fertility. And are you going to take a look at that when you are doing these studies? So we make sure we bring that voice into the room. And we want to make sure that people understand science alone is not what's going to get us to the cure or what people need. Science is a piece of it, but we need to make sure patients are at the center of what we do. So a little bit about me. I was a nurse practitioner for many years at UCLA Medical Center, but before that, I worked in community health. So I've always been about the patient and the community, health equity, health literacy, and all of those things that I think are important when we're talking to patients. And then we can be authentic about what we're saying, and we are making sure we're using language that patients can understand, and we are providing the kind of services that patients can benefit from. So I think Gilead is one of the companies that's on the leading edge when it comes to advocacy and when it comes to community engagement and making sure that the patient's voices are in the room. TNBC or triple negative breast cancer is something that is a serious issue. It's a real serious issue for Black women. Black women are disproportionately impacted when it comes to TNBC, and young women are disproportionately impacted. So we make sure we have summits where we bring women, scientists, nurses, everyone together and have conversations about what we need to do moving forward. And so with that, I'm going to turn it back over to you, Mary. No, Deborah, don't go away. You said something that's really important. It's Black women are disproportionately affected by triple negative breast cancer. And yet most of our clinical trials, as you know, if you look at the demographics, about less than 2% of patients who enter trials are Black.
Yeah.
And not that different of a number for Hispanics. What mission? And then I'll let you go. I promise. And I want to put you on the spot. You're keying into what I wanted to hear.
Yeah.
What mission? What issues are you putting forward for those unmet needs? How to gather? How to educate neighborhoods? How to educate churches? How to educate different patient populations on either side of the river, in order for there to be more trust in the system and get more women to come on to clinical trials out of from underserved populations.
Right.
Did I scare you with that?
No,
Yeah.
but it's a lot. So I want to break it down to several buckets here because the reason I came into pharma was because that I was running clinic, not running, but I was one of the nurses at UCLA doing clinical research in HIV. And HIV scary for the Black community because it had been talked about as a disease for white gay men. And quite frankly, Black people thought, oh, that's one thing we don't have to worry about, and then it was like, oh, no, we do have to worry about it. And so I was doing clinical trials on pregnant women who were HIV positive. It's the first time they had trials where you could be a woman and be pregnant and get an experimental drug. And so, how many of you guys know about the Tuskegee study? Raise your hands. Okay, good. And so, because of that Tuskegee study, for those of you who don't know, this was a study where they studied men who had syphilis, and when they had treatment that would get rid of syphilis, they didn't treat these Black men, and so they followed the men to see how long did it take for them to get blind, how long did it take for them to do all these other things, and so there was a lot of suspicion in the Black community about clinical trials. People didn't know what clinical trials were, but they knew what Tuskegee was. And Tuskegee actually did some good things as well as bad things. One of the things that they did was IRBs were formed because of Tuskegee, institutional review boards, which was not something that didn't happen before. And so while I was doing that study, I, being from the community, was able to go back and talk to people, break the science down. And, health literacy, medical trust, all of those things have to be addressed when you're talking about clinical trials. And then you need trusted voices. I think we learned from COVID, right? If you go to the churches, if you go to the bar shops, but you have to train people so that so it's what do I want to say? It's a bi-directional. Yeah, I'm saying with my hand, right? But it's a bi-directional conversation that's happening because women who I saw in those HIV studies, they were like, "I'm scared. What if this doesn't work?" And I had to walk them through it. And so they needed someone that they could break verbs with. They didn't have to have perfect English. They didn't have to know all the science, but they needed someone that they could have a real conversation with. So that's what we try to do.
Bi-directional conversations mean bi-directional listening.
Listening, yes, both sides listening and both sides talking.
I want to thank all of you for joining us and for this panel discussion and just bringing to the audience some of the issues that are so important.
Yeah.
And I actually have a wonderful surprise now for all of us that's going to come on board. So I'm going to have everybody step out.
All right.
Okay. Well, let me just start by welcoming this panel. I mean, we've had quite a number of people up here, and it's really exciting. And I will say, Tiffany, building on what Donna just said about the confusion, chaos, and so on, is a perfect lead-in to what I'm going to ask you about, and I'll introduce everybody. But out of respect, Dr. Iyengar, who has a plane in 2.5 hours out of Albany, we're going to address some of the issues that have come in, and basically all of them are for you and for Jean. I'm just letting you know right now. GLP-1s, obesity, when do we use them? Should somebody who is a premenopausal thin BMI 23 even consider it to protect herself? The question I got on Monday. And I think we need to hear about those issues. And so, Neil, should everybody be on a GLP-1?
Is this on?
Why don't you come here?
Oh, it's okay. I'll sit. um, well, so again, this is let me just firstly say that this is such an inspirational meeting, and this is why I come back every year. I mean, it's really amazing. So for
those of you who have heard me speak before, I've had the pleasure of coming up here on Maria's invitation to talk a little bit about our research, which really started off by understanding how adiposity and metabolism fuels cancer growth. And there are certainly, we've really learned that there are several cancers that are really driven by metabolic imbalance and energy excess. And that's really what we've learned from the obesity and cancer link. And now, of course, with the availability of the GLP-1 drugs, this has really now expanded our ability to manipulate that relationship between metabolism, excess energy, and cancer growth. So when we look at this question of should everybody be on a GLP-1, it's starting to sound like that. Every news article you read is about how they're for this or that. But when we look at the cancer relationship, it's complex. And this should come as no surprise because the relationship between metabolism and even things like obesity and cancer is also complex. So, for example, we know that for premenopausal women, obesity or a higher BMI is not actually a risk factor for premenopausal breast cancer. There are some studies which suggest that a higher BMI may even have a slightly protective effect against developing premenopausal breast cancer. Totally different story for postmenopausal breast cancer, of course. So obesity is one of the leading modifiable risk factors for postmenopausal breast cancer. This raises the question of when is the right time to intervene, and when we start to hear about strategies for prevention, risk reduction, and this thought of everybody should be in a GLP-1, that may not be the right approach for the premenopausal individual or for certain other individuals. And I think we really have to look deeper than that, beyond body mass index, and really look at the state of the adipose tissue and the state of metabolic function to determine what's the right intervention for that individual. So I just want to give you two different scenarios, because the other question we get a lot is, I've been diagnosed with breast cancer. Should I take a GLP-1? And I'll tell you about a patient of mine who had triple negative breast cancer and was just getting started with stage 3. So she's just getting ready to start chemotherapy and immunotherapy. And she had a BMI of about 31. And for the year and a half before she was diagnosed with breast cancer, she had been trying all different strategies to lose weight unsuccessfully. She didn't really want to start a GLP-1. She was worried about the side effects, but she had finally psyched herself up to say, I'm ready to start. I'm going to start. She had gone through all the insurance hurdles and finally got the approval and was ready to start. And then, of course, the breast cancer diagnosis hits. So now the big question was, she's positioned to start the GLP-1, and she's now positioned to start chemoimmunotherapy for her triple negative breast cancer. The question that she asks, of course, is, should I start both? And I'm reading really positive things about GLP-1 and potentially anti-cancer benefits. Should I start both? So that's situation number one. I want to also highlight situation number two, which is perhaps even more common, is a lot of patients are on endocrine therapy or adjuvant anti-estrogen therapy. And as many of you know, that's a situation where a lot of people gain weight because there are so many different factors that are making it very difficult for the metabolism of that person to keep up with lack of estrogen. And so in that scenario, we get a lot of questions about, would this be the ideal time to start a GLP-1 to prevent weight gain associated with anti-estrogen therapy, or just the life changes that occur during the time of anti-estrogen therapy? So we've done a couple of studies now to address both scenarios, and we need to do a lot more research. But the first study that looked at outcomes after a breast cancer diagnosis and using a GLP-1 was an observational study. We looked at a cohort, very small cohort, of about 100 women when I was up at MSK, and we looked at their outcomes if they started a GLP-1 agonist or not. The first thing that we found was the women who took a GLP-1 agonist along with their aromatase inhibitor and tamoxifen did not lose nearly as much weight as the general population did. You hear about these drugs and people are losing like 15%, 17, even 20% of their baseline body weight. In the cohort that we studied of women on aromatase inhibitors predominantly, they were losing somewhere between 1 to 5% of their baseline body weight. And we thought that maybe it's a small sample size, a small study. About a year later, MD Anderson published their experience with endocrine therapy and GLP-1s, and they found the same exact thing in a larger population of about 2,000 women. So now we're looking more broadly across multiple different cancers. Dr. Faruqi and I are involved in a study at MSK where we're looking observationally again.
Neil, could I just interject?
Yeah.
And what about survival outcomes, disease-free survival? Is there a difference?
That's
Please.
that's a good question. So our study at MSK was too small to address that question. In the MD Anderson study, overall survival improved in people who were on a GLP-1 despite the limited weight loss. And we have to remember that women who have been and men who have been diagnosed with breast cancer, unfortunately, have a doubling in their risk of developing diabetes and cardiometabolic diseases. And survival is limited by that issue, really. If you think about it, we're curing the breast cancer, but we're leaving people with metabolic dysfunction. And that's really a focus of our research. GLP-1s help to address that. So in that scenario of the endocrine therapy, I actually do recommend taking a GLP-1, especially if you meet the indication for taking a GLP-1. I want to go back to the triple negative scenario because now there have been a couple of conflicting studies, and one of the perhaps most worrisome studies comes from the UT Southwestern group, where they looked at women who were treated with neoadjuvant chemotherapy and immune therapy and took a GLP-1 versus those who didn't. And in the GLP-1 group, the pathologic complete response rates at the time of breast surgery were 30% lower than women who did not take a GLP-1. So in that study, they looked at both mouse models as well as human tissues. And what they found was that the GLP-1s are changing the immune microenvironment we talked about earlier this morning in a way that perhaps is not letting the immune therapy work as well as those who are not taking a GLP-1. So right now we're writing draft guidelines, and right now we're recommending to hold off on the GLP-1 if you're starting immune therapy. If you're using endocrine therapy and you meet the indication for a GLP-1, which is having obesity or a metabolic disorder, then we cautiously say it's probably okay. Now, for the folks who are looking to either microdose or use it for other reasons, we just don't have the data just yet. I think there are scenarios where that is probably going to be a successful approach.
Well, let's step away from the usage of GLP-1s and talk about obesity and aromatase, which we're trying to inhibit with our endocrine therapies. But from what I remember, what I understand, it actually increases in the breast cells.
That's right.
Increases with obesity.
Yes. So what's really interesting is when you look at studies, the original studies that compared aromatase inhibitors to tamoxifen and showed that for postmenopausal women, aromatase inhibitors are more effective at preventing breast cancer recurrence than tamoxifen, which is why we predominantly use that in the postmenopausal setting. Where if you compare obese individuals to non-obese individuals, it turns out that the benefit of aromatase inhibitors in the setting of obesity goes away. And our research has identified that it's because the microenvironment in the breast tissue, as you said, is actually producing the enzyme aromatase. And so the aromatase inhibitor, it's a pharmacokinetic issue. You're producing too much aromatase in the setting of classical obesity, or what we call normal weight obesity, which is essentially if you have a normal body mass index and your body fat levels are above 30%. So I actually tell all of my patients, we're going to follow your body composition, not your total body weight, because what I'm looking for is keep that body fat level, the total body fat level, less than 30%. And sometimes a GLP-1 will help that.
Two last questions, and I'll let you go to the airport, I promise. Alcohol and phytoestrogens.
Yes. Okay.
Need I say more?
I'm not gonna make it to the plane. This is this is a whole different topic. This is an important topic, of course.
I've got an extra bed.
So let's start with alcohol, and I'll just say one brief thing and move to phytoestrogens. And I hate to say it, it pains me to say it. There's no safe level of alcohol. There is no safe level of alcohol. Unfortunately, it is a poison, and it is not doing good things to your body. Now, the flip side to this is that we know that it comes with a social construct. And there's plenty of research that your social environment is incredibly important for not just your mental health, but may actually impact what's happening in the tumor microenvironment. We've got researchers at Emory who have shown that stress levels modulate the immune cells in the breast tumor microenvironment. And so what we need to figure out are competing risks. If have you hit that right balance of just the right amount of alcohol to make you optimize your social life? Or do you even need that alcohol to optimize your social life? Right? That's the lens that I look at it from is it's really finding that right balance. And if you're using alcohol as a tool to enrich your social life, maybe we can make a case for it. But if you're using it because you feel compelled to, because that's the social norm, then I think we have enough evidence now and momentum now. You know, when we take our young trainees, our residents and fellows, half of them say they don't drink alcohol anymore, which is amazing. So I think we need to reevaluate this from the lens of what's the optimal balance. It's all about balance. That's sort of my short spiel on alcohol. When it comes to phytoestrogens, this is an issue that comes up because people will ask about soy, right? And we know that soy contains phytoestrogens. In fact, a lot of vegetables contain various phytoestrogens. Chia seeds and other products like that also contain phytoestrogens. And I always take it back to a study that one of our colleagues did at Memorial, Jackie Brumberg, years and years ago, where women who were diagnosed with breast cancer were randomized before their surgery to consume a soy shake versus a non-soy shake. And what they did was at the time of surgery, they looked at all of the usual things, the size of the breast tumors. Did the soy make the tumor grow more? Did it make it more resistant to the therapies people were getting? Of course, the therapies have changed since then. But what she found was if you look at the genes of the tumor, the growth genes were turned on in people who were consuming high doses of the soy shake, but it didn't seem to have any other implications. The tumors were not bigger, they were not more resistant therapy, it didn't worsen outcomes or anything like that. So ultimately, what they saw when they started asking questions about, well, what was your diet? What was your physical activity level? It turns out that the people who participated in the study saw the shakes as like a health tool. So they improved all aspects of their life. They exercised more, they ate more vegetables. And so I really look at this from the lens of what are you doing with your lifestyle as a whole? And if soy is part of a healthy vegetable forward meal, say at least 80% minimally processed plant-based foods on all of your plate. And if part of that is soy, especially edamame, that's healthy. And some of those phytoestrogens, we've learned that some estrogens are anti-inflammatory. Estrone can be an inflammatory estrogen, whereas other estrogens can be anti-inflammatory. So if you trust the source of your soy, it's got to be high quality soy, minimally processed, then it can actually be protective, and that's partly because of the specific types of estrogens and phytoestrogens that are in food.
And do you continue to say moderation or is daily intake okay?
I say two things about the phytoestrogen intake. I definitely say moderation is important. So I wouldn't, drink 3 glasses of soy milk every day. But if you start off having a soy in your coffee or even a glass of soy milk for breakfast, that seems to be fine. And in fact, it may be helpful. And if you're replacing certain things like processed red meats with soy products, that's a good choice. So I say, moderation is key. And then the second thing that we have found is very important is sourcing. And this goes back to the epidemiologic studies. If you look at the breast cancer rates historically in East Asia and Southeast Asia, where they use a lot of soy products, the rates are lower. But as Westernization started to occur, breast cancer rates have really gone up. And one of the features that might be contributing to this is the shift in the way that soy is now and soy products are now produced. And I think this is an area where we have to be very careful because some of the production methods for highly processed soy-based foods can foster the highly inflammatory phytoestrogens rather than the protective phytoestrogens. So I do prefer, if you're consuming soy, that it's minimally processed. Eat the edamame beans, and avoid products that are, fake meats, for example. Those are highly processed, lots of salt. Just really keep it to the basics.
Neil, thank you so much. Let's get you to the airport. You're a joy to have here year after year. And now I could have a Manhattan when I go home.
With a social
Well,
circle.
safe
Thank
travels.
you.
Safe travels. Is Bob Bush in the audience? Come on up. So I'm going to show a quick video.
Hi, I'm Maria Visa, a breast cancer survivor or thriver, or I like to say veteran, having gone through surgery, chemotherapy, and radiation. I love the word veteran because veterans find their mission. They find their voices. They are brave. They come out the other side. Changing the words helps change the thought, which helps change the future. Let's change survivors to veterans and get 20% off everything, everywhere.
What do you say? From here on, it'll be the veteran program. Okay, so I always say to my patients um, the same thing over and over again. Keep your healthy parts healthy. They're going to be your best friend when the time comes and you need those best friends. I had a young patient come in to me and athletic, ate great diet. I mean, everything was just perfect. Um, I mean, it was why me. I did everything right. I had my children young. I breastfed. I keep good diet. Why do I have this breast cancer? And I said, well, if you didn't do all of those things, it could have been much worse. All right. That's number 1, 2, and 3. And there's no question that oftentimes, whether it's surgery, with all due respect to our great surgeons, whether it's medications, with all due respect to our oncologists, radiation, sometimes patients walk away with byproducts of those treatments. And there's no question that it runs the gamut. And one of the issues that we have begun to understand is cardiac health issues, that many of the drugs we used 40 years ago and 30 years ago can have a cardiomyopathy associated with it. We have now immunotherapy and in other malignant specialties, CAR T cells, which can have their own issues. And so a specialty called cardio-oncology has been developed. Needs to be there for our patients. I try to have all of my patients to see someone who is versed in the drugs that we use. And Dr. Uzilia, Jeffrey Uzilia, is a cardio-oncologist based in Albany with Capital Cardiology, who soon is going to have offices at our new NYOH Cancer Center. So we'll just be rolling patients down to you. And not because, yes, that's great. That's great. And and the truth of it is, it's not so much waiting for somebody to drop their ejection fraction or to come symptomatic. It's how to be proactive based on what the patient brings in to the room and what the patient's been treated with, to be proactive to avoid developing these issues. So Jeffrey, I'm going to throw that at you.
Thank you. Is this on still?
Do you want to come up here?
No.
Nobody
No,
wants
I'm
to come
sitting.
near me.
Does that seem to be working? Okay. All right. First of all, thank you for letting us come to your office. We're excited. More excited about that office than the new Casa, which is a little bit further down near Crossgates. So Dr. Heather Staher and I are the two cardio-oncologists in our office that are very interested in this field. We talk, on a regular basis about cases. We talk to her all the time, and we kind of, when we talk about these things, we say it's the best part of our job. It's our favorite clinic. We really enjoy working with the oncologists and working with the patients. But going back to your question, so the classic kind of case that we used to be involved with was anthracyclines, Adriamycin, watching ejection fraction and dealing with the consequences. And now it becomes so many different things As you guys as oncologists have done such a great job in terms of treating patients, and now we have people that are surviving long periods of time and seeing effects of therapies that maybe weren't optimized in the past, higher doses and radiation. So we see all kinds of different effects from the treatments that patients receive. And then I think now there's kind of that second part, and I think Neil alluded to that, is women in general, not just patients with cancer, get underdiagnosed, undertreated with heart disease. So all these patients that walk in, they may have other reasons to have heart disease that have nothing to do with their cancer treatments or their diagnosis. But now we're fortunate. We've got a lot of tools to use. We've got diagnostics where we can look at arteries, valves, lining of the heart. We have therapeutics where we can kind of modify the effects of HER2 new therapies. And there's lots of times where we'll do that very proactively, where somebody's on high blood pressure medication. Like, well, if you're going to be on a blood pressure medicine anyway, why don't we put you on something that protects your heart through this process? So there's lots of things that we can do in a proactive manner, and that as a result of all those things, there's lesser times that we have to say, really worried about this. I think we have to go a different direction, because that's not what we want to do. We want those patients to receive whatever you think is the best for them.
Wonderful. Within the umbrella of cardiac care and within the umbrella of cardio oncology, it's also all about overall general welfare. Uh, you know, uh, Making sure that anything that might be inherent to the patient is picked up early on. And sometimes we're finding diagnoses that we would have never known if they weren't just sent for, being cared for by your group. So I think that's all important. I really do. And I thank you for that. So cardio oncology is going to be at NYOH next door to Costco. And it'll be so easy to get patients to you. So Sandy Sanderson. Okay. Sandra Sanderson is a physical therapist, basically a rehabilitation expert who is probably the most sought after physical therapist in the Capital District. I don't know how you say yes to every single consult that we said. Look at her face. Um, and it's so important because, yes, women do develop lymphedema, and sometimes it's not just in their arms. Sometimes it could be at their mastectomy site or in their breast. And it's not just troubling to the patient because they have this swelling, but it's a reminder that they had breast cancer. They kind of can't get away from that diagnosis if they're having these adverse events. So, at what point in time should you be seeing the patient post-op? When symptoms develop, or when there's a centimeter expansion of one arm over the other? Or should you be seeing everybody? You should have an office in YOH too, and just see all the patients in order to be proactive.
Thank you, everybody. It's nice to be here. You're right. Actually, everyone should see a lymphedema therapist either pre-surgery or shortly thereafter, simply for the education alone. A lot of folks will come to me maybe a year later and they'll say, I wish somebody had told me. So I do a lot on education, and some surgeons send folks to me pre-op, mostly because they're like, I know this patient is going to have a complete axillary dissection. We're taking all of the lymph nodes. The cancer's aggressive, so therefore we need to have a lymph therapist on this right away. Get a compression sleeve, educate them on, no blood pressure in the arm, no needle sticks, et cetera, heavy repetitive activities. All of those things are so important to know right out of the gate. True story, 2 months mastectomy and someone's out power washing her house because she thought that she should do that. Now ended up with axillary cording, which basically you angered your lymphatic system. Now you have cords that go from your armpit all the way maybe down to your thumb. And those folks are 2 times likely to develop a lymphedema than folks that maybe behave themselves. Also, you have to remember, years ago, the amount of lymph nodes you had removed basically determined whether you were going to get lymphedema or not.
It was a minimum of 9 or 10.
Right. Now, at the age of 54, my mom had 19 removed plus radiation. She's 87 now. She was not the best patient. She did everything wrong. Heavy lifting, didn't wear a sleeve, I could go on. Luckily, she's escaped a lymphedema. And I say, well, why is that? And then we could have an entire room just like this, lymphedema half and half would say, well, Mrs. Jones had 3 nodes removed and her arm is huge. And then Mrs. Smith had 19 lymph nodes and never had a lymphedema. Well, why is that? There are a couple of studies out there that show, let's say, speedy lymphatic system versus a sluggish lymphatic system. You would think speedy would be great, that lymph's going through, but take an impairment of 19 nodes. Now you have lymph vessels traveling from the fingertips to the axilla, and they get up there and like, oh, there's 19 nodes gone. Now what do I do? Well, of course, I'm going to make regeneration. That lymph is going to regenerate to find a new node. But in the meantime, if you had a speedy lymphatic system, think about a 4-lane highway, 4 cars barreling down to get on 1-lane bridge. They're not doing very well merging because all that speedy lymphatics is going, and then they're trying to get on a bridge. You're going to develop a lymphedema. You have a sluggish lymphatic system, probably my mom, where their cars are poking along, and then they develop this nice, way of interweaving and getting onto the 1-lane bridge. Fine, they are spared a lymphedema. That's one study. Another study showed that if you already had axillary involvement, in other words, your cancer had spread from your breast into your armpit, you had sprouting, right? Your cancer wanted to go. So you've got lymphangiogenicis. So basically, your lymph has already sprouted. Now comes along a surgeon, they remove the tumor, and they remove the nodes. Cancer's all gone, but the sprouts are still there. So that's actually helped you almost avoid some swelling in the arm simply because you had the sprouting. And lastly, our anatomical development, right? We know that 2/3 of the population out there have an arm that is basically intact lymphatically. It's called a long bundle arm. So they can inject into cyanide green at the wrist, and they can watch it travel up into the armpit. And there's a perfect lymphatics. There's no disconnect anywhere. Then we have 1/3 of the gals, and all of us lymphatically are, we don't know. We don't know until we come upon this. 1/3 do not have an intact lymphatic system. They were born with disconnect, typically from the elbow up to the armpit. So this could be an understanding why, so-and-so had 3 nodes removed and has a very swollen arm because maybe she has a disconnect. And then the other folks who have 19 lymph nodes removed were developed a lymphedema.
Are you seeing a decrease in lymphedema now with sentinel lymph node biopsies?
Yes, thank you, Jesus.
Good.
Yeah.
And
The
what about lymphatic
surgicals,
transplant? I
yeah,
don't know. Yeah.
yeah. The just differences in surgeries and radiation alone have really lessened the arm lymphedema, but we do see a lot of breast lymphedema now, more than ever. I've been doing this for 25 years, and the breast lymphedema has exploded, the truncal, everywhere. So we're addressing that more with manual work and also garments. You see a lot more compression garments.
I am a big believer that there is a need for more resources, more of you, more of a wider clinic supporting you, or even grant, perhaps a federal grant. So everyone who has surgery has to come by your clinic pre-op and post-op. I really do believe it.
It would be
It's
wonderful.
just a chronic reminder. With that, I'm going to jump down to the end to Francis Ford. And Fran, I don't know what I would do without you at NYOH. Francis is, she goes under the title of social worker, but she's not just social worker. She is the one who understands the psyche, the heart of patients. She knows what it's like to have a 7-year-old child whose mother is going through end-stage disease, and not only to deal with the family watching the patient, not only to deal with the patient, but how to deal with a 7-year-old child, which often can be devastating. Individual therapy, group therapy, telehealth therapies. How do we divorce in a patient who is without evidence of disease what I see, thankfully, in a small number of patients, the diagnosis, just having the diagnosis causing such fear and anxiety, even in an NED status, patients are living as if they're stage 4 when they're not. What tools, what do we have, please?
Sure. Thank you so much for having me. Does this you hear me? Um, so again, thank you for having me. I mean, I think the first thing I always like to say is that I say to most patients are all feelings are natural. I think that so often there's an expectation, I have no evidence of disease. I'm supposed to feel positive. I'm supposed to feel happy. I'm not supposed to feel anxious. And so I think the first thing I always like to talk about is to think about all our feelings as natural and expected. When we go through treatment, we expect maybe nausea, we expect a lot of physical symptoms, and maybe we don't talk enough about there's also an expectation that we're going to have a lot of different emotional symptoms. And so I think the first place to start always is to name that, and to realize the feelings of sadness or anxiety or fear are just as natural as feelings of gratitude and positivity. Um, I think also often my referrals don't always come when someone's first diagnosed. That happens, but often my referrals come when treatment is over, when someone is settled into treatment, years after treatment is over. And I think that's often because it takes time for our emotions to catch up to diagnosis. So oftentimes there's almost the safety in treatment. There's a safety in going to treatment every week. There's a safety in scans because I'm doing something. And when there's nothing more to do, that's often when we sort of sit back and say, oh my gosh, what just happened? And so that's often when I come into play too. And so then what do you do? And so my goal is always to try to figure out what is a way that we can get the support that you need. And support can look like so many different things depending on who you are. So for some people, it's individual counseling. It can be really helpful to have a space away from our family, away from our friends who we often are trying to protect. I'm fine. Okay. Everything's going to be fine. And I have someone separate to talk to. Sometimes that support can look like a support group. What I really need is to talk to other people who are going through this. And that's where I'm also going to just sort of make plug that I can also be true for loved ones and caregivers. I need a place to talk about what it is to care for someone that's going through a cancer diagnosis. Sometimes I don't need a therapist, but I want a one-on-one mentor, someone who is a little farther along in the journey than me. How did you cope with that? How did you deal with that? So my goal always is to, one, really acknowledge and normalize the feeling. And so I'm here to really say whatever it is that you're feeling is okay. We might not talk about that feeling, but it's natural, it's expected. Someone else out there is feeling it too. And then what kind of support do you need to feel better, to feel heard? Emily mentioned the writing workshops. Some people don't want a support group where we're talking sort of just about feelings that might not feel right to you, but have an opportunity to write about what's going on in your life, write about your cancer experience in the context of other people that have been through it can be really helpful. So in my mind, asking for support is the number one thing to do, and then working with the social worker or therapist to figure out, and what does that support need to look like for you. So
There's not enough of you. I will say this out loud. We are very poor and in need of mental health resources overall. And I don't think it's just up here, I think everywhere. Um, Certainly in the oncologic arena, where just the word alone can paralyze someone. And even with stage 4 disease, advanced disease, I viewing it and the way one lives their life and continuing to exercise and be social, as Dr. Iyengar was saying, even within that arena, it's so important for overall survival. Um, there's just not enough of you. So I think Sandy and you should go off in the corner and figure out how to clone yourselves. Or everyone in the audience demand that we hire and do better and recruit people. That's what we need for all of us. Tiffany. Dr. Troso Sandal spent a couple of decades at MSACC, medical oncology. And did you just breast?
Breast and GYN.
Breast and GYN. Okay, you're going to stay on this platform. You recently wrote a book, and it's coming out for publication September 1. And so,
It's like a 3-year-old baby coming out at this point.
oh boy, oh boy, and I have to say, when Donna was up here, and talking about how she wrote her music allowed her to get away from her disease and function within some normalcy, maybe diffuse the chaos and the scatter and the fear. Do I have to say any more? Do you just want to continue what I'm talking about?
So my book is called Calming the Cancer Chaos, and it's a book that lived inside of me for 25 years building, and it was grown out of learning from my patients, not just what medications they need or what the chemotherapy was. I always used to say medicine's almost easy. Everything else is somewhat what's harder. And so this book is intended for patients that have developed cancer. It's primarily focused on women to help them understand the cancer, the whole journey. What is a pathology report? How do I read it? What are the different radiology studies that I might come across? Different surgeries? Who are the other specialists that might be available to me that could really help enrich my experience? And I also spend a lot of time explaining how important it is to not just understand the words, but to also feel the confidence that you are the most important person in the room. And that as a patient, it's very important to empower yourself to get the best outcome that you can, not to be a passive patient. I often use the phrase become the CEO of your cancer care, your cancer executive officer. You're in charge. And so if you don't understand something, you need to ask. If you don't get along with your oncologist or they're not explaining something or whatever, you don't like the color of their hair, I've heard that, maybe you need a second opinion. Either way, at any rate, I could go on and on. It is 250 pages. The point of the matter is that I think it's really, really important for women, especially, to take their place in the exam room and realize that they need to put themselves first, maybe for the first time in their lives, and make sure that they're getting the care that serves them best. Because I've found over the years that not every single patient has the same outcome in mind. A patient who wants to go to Florida for the whole winter with her husband because that's where they thrive, well, maybe she's not the one that needs the weekly chemotherapy that only can come from my office. Maybe we're going to work with another oncologist in Florida and coordinate that care. Maybe the patient who has young children and nobody to help care for them, she needs additional support so that she can actually get to her treatment. So there are so many things that I've learned about from my patients behind the scenes that are more than just specific medicine themselves. But part of my book, the purpose is to educate you on the parts of the oncology medicine so that at least we have the vocabulary to understand and to communicate with caregivers, our loved ones, as well as all of our family and friends who want to help us.
Can you talk about the workbook that accompanies the book that you wrote?
Oh, thank you so much, Maria.
Very, very important.
Thank
Very
you. First, I also have to mention that Maria was an
And it comes
extremely
free with book.
Dr. Theodoulou was an extremely important part of this journey. I thought I had finished my book.
I read the first draft and I told her I didn't like it. How do you like that?
My husband was sitting in the room. I put the phone on mute. I go, oh shit. Oh, I didn't say that. Anyway, but she added so much value to what I was saying. She let me step back and really read the words as a patient. And although I knew I was writing to patients, I think you really helped me find my voice. So thank you. Okay, so the book is being published on September 1st, and it does come with a 145-page workbook that I created that is free PDF download that actually enables you to not just understand what you're reading, but actually put it into action. So I have pretty much everything I could think of that a patient would possibly face through their journey, and how to document it, and how to create a journal, and how to make a binder to organize all of your things. And the foundation has very generously offered to pay for some of the books or all the books. If anybody is interested in purchasing it, you need to pre-order today, and that's the QR code. And so I would be
We will
absolutely
support
honored.
it.
Thank you so much, Maria. I appreciate it. And I really hope that if anyone gets a chance to read it, that you find it helpful. And it's my heart and soul. I feel like it's almost the culmination of my career, though it's not, 'cause I'm only 57.
Congratulations. I'm very proud of you.
Thank you.
The issue is I've been asked multiple times throughout my career to read something, prove something, give advice, and I'm not a yes person. And so sometimes I say, no, no, no. I will say when I reread it, I was so very proud of you. I would give it to all of my patients. But you said something. Women often don't put themselves first. And that is my segue, Jean Carter, because we are caregivers, we are career women, we are warriors, we are doing everything all the time. And oftentimes we don't pay attention to one of the things that makes us comfortably whole. And Dr. Jean Carter is the chief of sexual health at Memorial Sloan Kettering Cancer Center. I worked with her when I was at MSKCC for years and years. I continue to work with her since I left. Um, it is such an unmet need because women don't talk about it. And we have to find a way to create that voice because it's not just about penetration, it's about our overall health, how we pee, how we feel, if we're comfortable. I'm gonna stop talking. Jean, it's all yours.
That's a great
And I have
transition.
multiple questions here, so get
Oh,
ready.
wonderful, wonderful. No, I think a lot of what's been said today is really nested in what I do. I think I always tell my patients, cancer's taken enough, we're not going to let it take more. And the key to this is to find it's going to be a bumper sticker one day. Cancer is taken enough, we're not going to let it take more, right? And I think it's the key for all of this is there are so many changes that happen so fast and it's daunting emotionally, physically, spiritually, and you're trying to take care of yourself, but it feels like a full-time job. And then taking care of yourself from a women's health standpoint feels like something that maybe is a luxury you don't have time for, you worry about costs, but it is so important for you to find a way to help your body to heal and find balance. And, a lot of medications that are wonderful and helping our patients live longer can have very dramatic um, results on vulvovaginal health, which, maybe you had just hinted at, going to the bathroom. That's true too. I mean, you can't not use this area. So women are having painful exams, risk for UTIs, discomfort with daily activities, working out, and just don't know that there are simple solutions. That does then translate into intimacy and comfortable exams. So I think we just do a disservice in our society of not teaching women how to age gracefully. Estrogen is natural moisturizer. So when you don't have that, either you have to put it back, which is a big source of conversation and controversy, but you can put things that are hydrating, that are non hormonal, that are over the counter, that are very simple, that are being marketed out there for just general menopause. But if you do that without guidance, you will not get symptom relief because what women go through is not a natural transition. It is usually quite a drop off. So we have studied products that are hydrating, that have hyaluronic acid, which is in every facial cream. I know people are using it on their face. You can literally use this in your vagina and apply it also on the vulva, which maybe people talk about the vagina. Nobody talks about the vulva, but the vulva is important for women. From a sexuality standpoint, the clitoris is external. So if you're not moisturizing that, it can have changes in tissue quality, sensation, comfort. And then there's also the opening of our vagina, which we call the vestibule, which is where women usually have burning discomfort after exams or sexual activity because the tissues are so fragile when they're thin. So these products can be used both internally and externally, but at a higher frequency. We know from studies that it needs to be 3 to 5 times per week. We do it at bedtime, so gravity works with you, not against you. I call it my skincare everywhere to try to get women to pair this with their routines at night. So it doesn't feel like another chore. It doesn't feel like another task because I do understand there's a lot of things you're doing, including massage, for lymphatic drainage. And these are things that if you can incorporate in, just will have a huge impact just on your life and your comfort. And a moisturizer is not a lubricant. And I know a lot of people know that, but in case you don't, a lubricant is something that's there to supplement your natural lubrication. That's why you get with an exam, doctors put a lubricant on. If you're going to have sexual activity, as we age, our lubrication response is not as robust. That's why we have all these wonderful products, but they're temporary, they're a band-aid, and they're not moisturizing. So if you're going to put time, money, and energy into healing your body, it serves you well to use something that is hydrating, both internally and externally. And if that's not working, then there are options sometimes for low dose vaginal estrogens for women who have chronic UTIs or tearing or discomfort. And we have done studies at Memorial looking at estrogen levels. Low dose vaginal estrogens are available in a low enough prescription that it's not causing any elevated sustained peaks, which is what all medical oncologists worry about. So there are great conversations that you can have with your providers if this is an issue for you, but definitely I would say start with the over-the-counter, non-hormonal, do not require prescription healthcare products that are used on the face that can be used in the genital area that just can make a huge issue in your overall quality of life and comfort.
Jean, you're in the under GYN service at a major tertiary cancer center, and I'm imagining that you're getting a lot of your referrals from the GYN physicians. But what about the general population who's seeing their primary care physician or who's seeing their medical oncologist? How does the conversation happen? I know in my clinic with my nurse practitioner, it is part of our routine. It is part of our review of systems. We bring it up, we talk about it. It takes time. It takes time. But how do we educate our patients to feel more comfortable about that conversation, that it shouldn't be something hidden in a closet?
Well, I had a question one time from a radiation oncology resident who said the same thing. How do I bring this up? And I said to him, well, do you screen for menopause? And he said, yes. And I said, well, that's where the conversation should start. So if you're not comfortable talking with your provider about sexuality, which not everyone is, women's health is something we should all be talking about. So you can say, I'm having some changes in the tissue quality. I'm having some discomfort with daily activities. Or I had someone say to me, like, I got on a bike and it was really painful. Or I wore my favorite pair of jeans and now it feels like sandpaper. Like you can just bring up that there are changes that are going on that you're not understanding. There are so many great information, patient education, services out there. I mean, you can Google it online and information comes up. So don't not have the conversation if you're not comfortable talking about sexuality. Start from the standpoint of it was uncomfortable to have an exam. It was uncomfortable maybe have sexual activity. That's also very important to discuss, but I want to come from where you feel comfortable. We should all be advocating to have comfortable sexual activity and conversations and make that forum not feel so daunting because people say to me all the time, is it just me? Am I the only one? And then I'm like, well, we have a program. No, you're not. But I do think it's important to at least feel like you can bring this up. It's on our job as the providers to make that safe space. And I was talking to someone the other day who was saying like conversations aren't happening. I'm always thinking about like at Memorial, like we move in packs, sometimes in packed 'cause it's not easy to have the conversation. So, you could ask your provider, is there a way that you could, just talk to them for a moment or grab the nurse or if you're with a family member, just ask for a moment when you ask them to go get you a cup of coffee or water. Like the environment is so important for these conversations to happen. We need to have more screening tools so that we're identifying that so that we also can initiate that conversation. But I think it's important to advocate for yourself 100%. Like you deserve, you've worked this hard to be here. You deserve to have quality and comfort and joy.
It's not age specific. My younger patients bring it up all the time, but
You have 80-year-olds. Don't say just young. I have 8-year-olds in
No,
my
that's what
clinic
I'm
too.
getting to. We can't discount our 70s and our 80s.
Yes.
About 25 years ago, I had a 79-year-old female on an aromatase inhibitor, and she was coming in for routine follow-up. It was 3 months after I started her because I wanted to keep an eye on how she was tolerating it. She came so angry at me, angry, 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 and I was, paralyzed, and it doesn't. I mean, I talk. I couldn't even speak, and I tried to call her, and I said, "Why are you so angry at me?" She said, "Because my husband's angry at me." I said, "I don't understand." She said, "It hurts now when he wants to have sex, so I don't have sex." He's blaming it on the medications. 79 years old, and she just wanted to have a robust, healthy sexual life. We started the conversation. We had the conversation. I had her see someone in your department. I think maybe it was you. I don't know. Came back on her next visit very happy. So was her husband.
Can I just can I just say one
So
thing about the
question. Oh,
older
yes.
about the older population? Incontinence is a very common thing as we age, but I have found that it can have a huge negative impact on vulvovaginal health. Women are wearing pads and panty liners. You see all these commercials now for the pretty pull-ups and everything, but they do have an impact that if you need to wear a panty liner or a pad, wearing a barrier cream is so important. Otherwise, the tissues just
Yes.
dry out. Women like scratching themselves, so we call excoriation, and just it's terribly painful. And we learned about the barrier creams actually from our colorectal and anal cancer patients post radiation. They're having a lot of GI issues, and these creams were truly their lifesaver. So,
I'm so glad you brought this up.
yeah, try to avoid panty liner and pads if you can, because they really do their job, which is to wick away moisture and the plastic adhesive smothers everything. If you have an incontinence issue, you must look into barrier creams to protect those tissues.
So I have one question, and Fran will take away my mental health if I don't ask it. Um, what are the current FDA approved treatments for lack of libido and vaginal atrophy on patients on hormonal therapy?
So FDA
Should I order dinner?
No, I'm not going to dominate this. Just a few things. So FDA approved medications for hypoactive desire disorder are bremelanotide or Vyleesi, which is a sub-Q injection. It's non-hormonal. That's what I want you to remember. All the medications that are now coming out for desire are not hormonal. They're working on the dopamine, serotonin pathway, working on brain chemistry. The other one is fluancerin or Addy, which is now marketed as the pink pill. I mean, I guess to go against the blue pill. It's definitely inspiring to see that the pharmaceutical companies are now taking the time to look at this in female sexual medicine because there's been such a heavy focus on male sexual function. But I do think there's not a panacea for improvement in these domains. We did a study, a national cooperative group trial with breast and GYN cancer patients, and we offered them Wellbutrin or bupropion, which is given to women who are on serotonin reuptake inhibitors like Zoloft, Paxil, because they can have sexually induced dysfunction. So we took all comers, and when they were writing the study, I said, please, you have to have them use strategies for vulvovaginal health. And they said, oh, we'll just if they want to use them, we'll let them use them. I said, no, 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 you need to have them use them. They said, no, we'll just let everyone use them. Okay. So the study comes out negative. Not a surprise. Even though clinically we've seen this medication be helpful. So we went back and we did an ancillary data review. And in the population of people where they were getting the bupropion, different doses, or placebo in all groups, the strongest predictor for having low desire was lack of lubrication and pain. So I always say, like, you want to improve desire, you have to take care of the basics. You have to make sure that women are having comfort, that they're not having pain, because it's hard to experience pleasure or to have interest if you're doing something that's not comfortable.
Or want to go through again.
Right. So that's desire. For vulvovaginal health, we mentioned this before. Like, there are wonderful strategies that are available over the counter that people can be using. The North American Menopause Society always says start there and work your way up. Low dose vaginal estrogens would be the next escalation. Sorry, tongue tied. I need more coffee. And now there's all this debate about HRT. And what we usually say is that we don't have the data to guide us. Like, are doing some studies in Europe, and hopefully we will have the answer for that. But the pendulum has swung. First, it was everyone was on HRT, then everyone was not on HRT. Now everyone's going back to that. When people tell me that they're having an issue with sexual functioning, I'm always saying, what are you treating? If it's desire, we have non-hormonals. If it's vulvovaginal, we have non-hormonals. If it's arousal issues, that's circulation. So that's really trying to work with devices. I mean, pelvic floor exercise and Kegels works the same pathway for your arousal response. But there are studies that have looked at vacuum devices, because whatever they use on men, they use on women, and they use vacuum devices to help them with erections. And that has shown to have some positive data. Vibrators has also been shown. So there are things that you can do that are within the realm of being non-hormonal and optional for you. And then you escalate as you need. And that's an intimate conversation with you and your provider based on your disease, your characteristics, risk, benefit risk, because there's a lot of conversation now about what if you're triple negative, like, why can't you do that? So that has to be a thoughtful discussion, but you really need to understand, what are you treating? How are you going to treat it, and escalate the things that are not harmful to you, and take the risk in increments based on what your need is. Have I answered your question?
Do you have a podcast?
No. And I don't write either.
Didn't she have a podcast? Yes. So thank you, Jean. That was great. We have a question, and I saved it for almost last because we're going to address bone health, and then we're going to finish up with some comments from Dr. Musk. You'll hear about them, and a short 3-minute video, and we'll close. But I want to introduce Dr. Aziz Faruqi. There he is. And you can come up here. You always tower over me. Do it again. And hi. So Dr. Farouk just came from Santa Fe, the Bone Health Conference, and thank you for coming up here. He is an attending physician of endocrinology at MSKCC, an associate clinical professor at Weill Cornell. His research, his whole focus is bone health, and I will say to you that I'm thrilled that you're here. I have a question that we can kick off with, but while I was scanning the audience, I found Dr. Robert Bush. And did you ever run across each other? He trained at MSKCC, endocrine up here in Albany, who deals with bone health. And I said, why not abuse Dr. Bush? He didn't know he was going to be up here, so we pulled him up here, and they'll keep each other sober. And let me ask you a question, then I'm going to move away from here. Will anyone be speaking on osteoporosis after the use of aromatase inhibitors, or maybe while on the use of aromatase inhibitors? What do you recommend when we should start these medications? Or do we have to wait until after all of our cancer treatment is completed in the adjuvant setting before we address our bone health? I'm actually going to go sit down.
Please.
Go for it.
Yeah, thanks, Maria. This is a great conference. I've been here before, and just an honor to be here. Yeah, like Maria said, I'm the bone guy. Once they realize the patient has a skeleton, they say, well, send them to Farouk. So, anyway, to answer the question, no, you don't have to wait till all your therapies are over. In fact, there's some really, I think, underutilized, expressed information that I want to get across here is that
some of these bone protective medicines are bisphosphonates, particularly, have two benefits in postmenopausal women with breast cancer who are on medicines that can make their bone density get worse and increase their risk of fractures. So these two benefits, one of them, well, they're bone protective medicines and they're going to protect your bone density and they're going to lower your risk of fractures. But the other one, if you're a postmenopausal woman with breast cancer, it doesn't matter if you're estrogen positive or negative, there's good evidence that they reduce the risk of those cancer cells coming back into the bone. So you can think of it as the bone is the soil, and the cancer cell is the seed. And these medicines, they make the bone, the soil inhospitable for the seed to recur there. So, if it's my family member, I literally tell patients that, yeah, I mean, I think this is very important information that you get these two benefits from taking this one bone protective drug that's not chemotherapy agent. It's an FDA approved drug to reduce the risk of fractures. And the one that, really has the most data behind it is zoledronic acid is the generic name. It's an IV medicine. And now, all that being said, these drugs have a lot of baggage and that, well, this, side effects that, what about these side effects? And we can get into all that. So the answer to the question, however, is that no, we try to block the bone loss. See, if we do nothing in a lot of patients, their bone density will tank. And even if they're young, we don't worry about them breaking bones when they're young as much as when you're older, but we kind of want to think ahead. You don't want to let your bones disintegrate and when you get in the soup when you're older.
Here we go. Can you speak a little bit about rate of bone loss? I can certainly order bone mineral density, and I can see if it's normal or assess whether there's been a change. It's there in black and white. I'm reading the report, but I'm not capable of evaluating the rate of bone loss or whether an intervention has to be put forward or whether there's some other process going on with the parathyroids or whatever. I can certainly draw the labs, but putting the whole story together, I think, is important. And are there patients who have osteopenia or even near osteoporosis who may not need medications because they're very slow losers of bone and they're leading healthy lifestyles? Can you address some of that?
Yeah, no, it's a great question. We all, tend to lose some bone as we get older. And that's with every year, 0.5 to 1% bone loss per year. And, when you go through menopause, there's an accelerated rate of bone loss for 5 to 8 years. Um, so that's just the way it works normally. When you get put on, estrogen blocking medicines such as aromatase inhibitors, um, in distinction to tamoxifen, by the way, in postmenopausal women, tamoxifen acts weakly like estrogen on bone, so it's kind of good for your bone. But the aromatase inhibitors rev up that bone loss. They accelerate bone loss. Um, so therefore, they also increase fracture risk and so forth. I think the point is when you look at these bone density reports, what I tell patients is that you got to look at sometimes like the stock market and look at the big picture, look at multiple time points to see where the market is going, right? Because you can get fooled in the short term because there's an error margin to the test. And it says it on there that, and most centers will calculate what's considered a statistically significant change in terms of the percent from one year to next year. So if you have a 0.1% change, that's non-significant, right? But if you have a 5% change, that's outside the error margin of measurement, which, let's say it's 2.5, 3%. So sometimes we look at it and see where things are going. Other point I would add is that, you can do a bone density after 1 year if you're concerned. And to answer the point that was brought up, that Dr. Theodoulou mentioned, is that what if you start out with really good bone density? And yeah, I think that's if you can just wait and see. You can see, well, what happened after a year? Did I lose a lot? There are situations where premenopausal women are put on ovarian suppression medicines who have breast cancer, and their bone density can go down quite rapidly, and it's alarming to some patients like that. But that decision, kind of relates to this concept of if you're a minimalist, your philosophy, or you're a maximalist, which means like some people are like, doc, you keep drugs. I don't want it. I've done enough. Like, I don't want any more drugs. They're minimalists, and that's fine. But other people are like, yeah, give me everything you got. Give me more. So, that's how, when somebody asks me, like, well, what would you do if it was your sister? I think that's a fair question, because my sister does have breast cancer now, but I can answer it from my own personal philosophy. I tend to be more of a maximalist with the bone drugs because I know that they're going to be safe. So, um, yeah, did I cover everything in there? Yeah.
Yeah, and I guess a question I have, you're in a tertiary institution. Uh, Bob, you're in the community. Although you function like an academic institution within your own office. Um, where are your referrals coming from? Are they coming from primary care physicians? Are they coming from their gynecologists? Certainly, we in the medical oncology field abuse endocrine. Virtually everyone is sent to endocrine. Um, where are your referrals coming from? And are you ever surprised to find out that you're seeing someone who just sustained a fracture and has not had baseline bone density? And how do you address that in the community, Bob? And what do you see in the tertiary centers? Oh, it's not.
Oncologists use steroids a lot, not so much for breast cancer, but if a patient's on steroids, that can cause fractures. And patients on steroids prophylactically go on medications to prevent bone disease. For the relatives of people with breast cancer, for postmenopausal women, give viloxazine if a patient, not only does it, if you're osteopenic, prevents the osteopenia from getting worse, but it also may prevent estrogen receptor positive breast cancer because it blocks estrogen at the breast. So that's something that we use favorably as well. And just to bridge back to the physician who left with the GLP discussion, don't take compounded GLPs. You don't know what you're getting. These are not FDA approved. I've heard of people who said, I want to get retatrutide, triple G, 28% weight loss. It's not even on the market, yet people are getting compounded Retta, particularly in New York City.
Where are they getting it from?
Well,
Online.
online. They could get it online because of the dramatic weight loss. You don't even know what's in there. The compounded therapies have other junk in there, and they've been studied leading to deaths as well. And it's very common for entrepreneurial clinicians to be selling these medications because the weight loss is sexy, and that's not something you should have done. There are a bunch of other GLPs that will be coming out in the future that are monthly GLPs, a bunch of different oral GLPs that are being ethically tested now. But don't fear, that wasn't discussed because of the breast cancer potential benefit. But GLPs, cardiology uses most as well. They lower heart attack, stroke, and death. They lower fatty liver going on to cirrhosis, called MASH. You see a lot of TV commercials about MASH with other drugs that benefit that. They treat fatty liver, they treat obstructive sleep apnea. So there are a lot of other benefits. So I know you asked, should everyone be on a GLP? If you're an endocrinologist, everyone is on a GLP because they're overweight
I
or have
think the three
diabetes.
initials, F like in Frank, D like in dog, A like in apple, FDA. If it's not FDA approved, don't. Just don't.
And most GLPs are compounded GLPs that people are getting because, unfortunately, for obesity, GLPs aren't off covered, except if you're 65 and over and on Medicare. GLPs now are covered. They're called a bridge program. They're $50 to get a GLP, ethically prescribed if your body mass is above 27 and higher. I would not give it to the BMI of 23 that you talked about.
Thank you. Aziz, I have patients on tamoxifen. They complete 5 years. Some of them are on even longer. And I know that when they stop the tamoxifen, they're going to have a dip in their bone density, on the following evaluation. Do we ever take that into consideration for prophylaxis?
Yes, and tamoxifen, like we were saying, is bone protective if you're a postmenopausal woman, not so if you're premenopausal. But yeah, if you have, low bone density, osteoporosis, near osteoporosis, if you have osteopenia and have had fractures, that would be something. If you're stopping tamoxifen, we want to give something to block the bone loss because it's like taking away the estrogen. So I would give some bisphosphonate probably to that patient.
Well, everybody will be available for a few minutes. If you have any questions, let's give a great round of applause to everyone. Dr. Muss and I were speaking earlier, and because his specialty has been geriatrics, we're changing the name of, and because of we're changing the name of it, and because there are so many issues by way of patients living longer now, getting to the point where they're considered geriatric successfully. There's so many other issues that we need to address and think about. And please take a few minutes and talk about what we spoke about earlier.
Yeah, so can you
So
hear
much for
me?
letting me you want me to-
Well, first of all, what a great conference. And Oprah has a replacement. That's right. So it's true. So Dr. Arena mentioned Christina today. So this was his neighbor that died of leukemia. And one of the miracles of oncology now is that most children who have leukemia and young adults are cured. So about 80 to 90% are now cured. And that's great. But what we forget, by the time these kids are 35 and young adults, about 20% of them have passed away of other illnesses. And some are second cancers. If you have one cancer, you're always at higher risk to get another one. And some of them are diseases of aging. They're heart disease, diabetes, other problems related to aging. And so what we've learned from the children is that a lot of the drugs we use, as good as they can have adverse events that occur very late after treatment. And one of the miracles of breast cancer now is most women with breast cancer now are surviving it. So in the United States today, the vast majority of women who get breast cancer are surviving it. And, we all love our oncologists, and you're 5, 10 years out, and you still may be seeing mental health about fear of recurrence, but you're really going on with your life. And you're not worrying about your breast cancer. But what we've learned is our drugs can precipitate things like heart disease, we've heard. Some women have nerve damage from a lot of our drugs and walk around with numbness and tingling. And then there are things we haven't talked about today, like chemo brain, right? We talk about it. Women told me about it all the time. What is it? And it may be it's a very real thing. It's very hard to measure, and it's real. So the research I've been interested in, and bless you, Breast Cancer Research Foundation, has been, can we look at women who have been treated for breast cancer and define those women who are at greatest risk for side effects down the road? And those side effects can be heart disease. We don't want to wait till they show up in the emergency room in heart failure. We want to know right after their treatment, is their heart damaged? And all the tests like echo tests and other things frequently don't show anything. Now we're getting better tests, MRI tests that do it, but we're interested in finding those women who have been treated who might be at greatest risk down the line for serious problems, heart disease, lung disease. We're talking about all these hormone therapies and depleting women of estrogen, and there are worries. Does that accelerate cognitive loss as they get older, the lack of estrogen? Things we're really interested in. So I've been fortunate to receive grants from BCRF and others to look at your bloodstream, measure your blood, and measure how old you are biologically. So you may be 50 chronologically, but you may be 60 or 70 biologically. And we measure that by looking at different chemicals in your cells, and we can be pretty accurate. Now, in an individual, if I measure your blood now and I see you're biologically older, I can't tell you how long you have to live. But I might be able to think of preventive measures on the possibility that that's true to make your life better. And it can be lifestyle changes, right? Exercising, losing weight, GLPs, whatever. So that's been an interest. But right now, we're moving into being able to measure in your blood. You've heard all about the circulating DNA. We can measure little proteins in your blood, little chemicals in your blood. And we can now begin to tell how old your individual organs are. So I can treat Mary Jones with adriamycin. And some of you may have had it called doxorubicin. Patients call it the red devil. Um, and we can tell every woman who gets that drug is going to have a little bit of heart damage. But fortunately, most of the women don't get enough of it to cause heart failure. But these ejection fractions, how strong your heart pumps that are taken after treatment, they're very inaccurate. They may look great. But 10 years down the road, someone may come in with serious heart disease. So we're trying to tell right after your treatment, you have a normal ejection fraction, you can walk 6 blocks. How old is your heart? And we can compare these chemicals with people who haven't had chemotherapy. So we can get an idea of who may be at greatest risk. And it's going to be years later of heart disease, nerve damage, perhaps early cognitive loss. We can do this down the road. So why do we want to know if we can't do anything about it? Well, we can do things about it. We can get you to a cardio-oncologist. We can get you exercising. We can get you to lose weight. We can make sure you've got maximal blood pressure control. We can make sure your cholesterol and all these things that are not hard to do are taken care of. And then we're hoping to be able then, if we can identify these higher risk patients, to also look at interventions like things like statins or other chemicals that may be helpful. And then the last thing I want to mention is we're looking at during chemotherapy. We know that a lot of women report chemo brain after chemotherapy, and they tell you they're confused and fuzzy. Most women get better, quality of life improves, but we're trying now to test chemicals, drugs that are available, memantine for things like mild Alzheimer's during chemo to prevent this. And so we're measuring women's cognitive function and then treating them during treatment, randomized trials to see if we can help them. And we're also looking at new drugs now in patients who have had chemotherapy. It's a billion-dollar business in keeping everybody young and giving everybody blood from 15-year-old kids out of, the billionaires who want to live forever. We're actually looking in a setting in women with breast cancer who have had chemotherapy. And after the first year, those women who can't walk about a quarter of a mile in 6 minutes, we're putting them on a study where we're looking at really grueling exercise regimens with coaching and an antioxidant drug called Ficodin. And you can buy that on the web, but don't because you're not sure what you're getting. And we're seeing if we can strengthen these women. And we're also looking at everything in their blood, like circulating DNA and their age of their organs, et cetera. So there's lots of exciting things. And we're interested in this because the vast majority of you who have had breast cancer are going to do well. And even the women with metastatic disease, many are living for years and years and doing well. So to me, this is where we're focusing now. And we hope going to be able to have women have long and high quality lives through this research.
I can't thank the faculty that made their journey, some from Houston, some from San Antonio, from Atlanta, North Carolina, Albany, New York City. What a treat today. I'd like to, before my closing mark, show you one video. Oh, that's me. That's me. Okay. This is one of my patients. I met her quite some time ago. Probably, I don't remember exactly, maybe about 7 years ago. She came to me with a high risk cancer, multiple lymph nodes. Her metabolism was such that she had very, very difficult times with her systemic therapy, whether it was chemotherapy or endocrine therapy or cell cycle inhibitors, often not being able to complete the treatment because of toxicity. Unfortunately, her disease did progress and she developed peritoneal metastases from her cancer. And her dream had always been to live in a home that she and her husband were building in, I'm not going to name the place, but it's the middle of nowhere, Alaska, truly in the middle of nowhere. You would have to get a plane to go to Juneau or Seattle, but breathtakingly beautiful. A National Geographic photographer who really, it was important, her quality of life, and made a decision because of intolerance treatments that she would no longer be treated. And she went to their new home and made a decision to move forward with hospice. But there was not really a hospice there. And there was no way for her to get medication when the time came to keep her comfortable. And decided to come back to me to discuss end of life, to discuss comfort care. And I said to her, look, let me just do one thing. Let me just draw a blood test, which looks for circulating cells, and see if we could identify any triggers or any new mutations in the cancer that has evolved today. Because we know that breast cancer, when it's found in the breast, oftentimes can change its face, change its profile, as it finds different places to make a home in. And I did send off that blood test, and I found out that she had a somatic mutation in ERB2. Now, and she was not approved for somatic mutation. I may lose my license after this, but I presented it. I got insurance authorization, treated her. She had a hell of a bad time with side effects. Finally, got her on core dosing, and her markers dropped. She felt better. And after 5 cycles of treatment, made arrangements for a medical oncologist. That was a bit of a plane ride away from her home in Alaska to continue her treatment. And they moved to Alaska. And I received this 2 weeks ago. Both Kim and her husband were celebrating their 20th anniversary. And she said she was sending this as a love letter to me. And I said, may I share this with my audience at the survivorship symposium, veteran symposium? And she said yes. So
hi, my name is Kim Clune, and I've been a patient of Dr. Maria Theodoulou's for 7 years now. When I was first diagnosed with cancer, I had just come to Alaska, and I was offered a job that would take me around the world as a wildlife photography guide and photo expedition leader. And then I was diagnosed and lost everything. There were dark days, and there were times I thought I would give up. I had been through rigorous treatment that was so hard on my body, more so than most people, that I was ready to quit. We knew life was short, and so my husband and I raided our retirement fund and we built this house. About halfway through the process, we found out my cancer was back. When we drove from Alaska to New York last September, we thought it was from hospice care. I was given one more chance. I have reached my 56th birthday, which I didn't expect to happen.
I'm making big, big wishes this year.
I've been able to enjoy my 20-year wedding anniversary with my husband, the love of my life. When we made our hospice journey, we drove through beautiful places where we would dance because we thought they were going to be our last dances. And this year, we came back and danced with Hope at the side of the river in Jasper with no music, just the current, and it was just magnificent. These lupins behind me, I planted them 2 years ago. It takes 2 years for a perennial to bloom, and I never thought I'd see the day. But I'm sitting here in my garden surrounded by them. But they did give me one little November surprise in their first year. It grew! Can't believe I came back to my lupins. Oh my God. Whatever you decide, whether you take the chance or you don't, there's no right answer. But taking the chance was the right one for me. I just want to say that when you think no hope is possible, sometimes it's the only thing there is.
I want to thank everybody who helped organize this. It was a short notice to get this program to all of you. I hope you all walk away feeling that you learned something today that you didn't know before, or feel inspired by someone's story or someone's music or someone's book. I'm grateful for all of you that are here on a beautiful Saturday. And there is a survey. I can fill it all out for you, you know. I want to thank you all, and I want to thank everybody at the NYOH Foundation. Rachel, are you in the room? I don't see you. There you are. Stand up. The faculty will stay a few minutes. There is a book signing. If you'd like a book signing from Dr. Rourke, there's a URL code for Dr. Trosso's book. I'm going to go home. I'm exhausted. Thank you all.